Good afternoon and welcome to NHS West Yorkshire Integrated Care Board. We are having a meeting today here in Halifax and gathered together our representatives across West Yorkshire in terms of our health and care leadership. And we also welcome today colleagues who are working in oral health and dentistry for our focus on topic today. My name's Cathy Elliott. I am Chair of the Board of NHS West Yorkshire, and as we have a number of new faces around the table today and some colleagues deputising, I'd like to invite everyone to introduce themselves very briefly. It particularly helps members of the public who've come to observe the meeting today and also people watching on live stream and record afterwards about the meeting. So, Rob.
Hello everybody, my name's Rob, I'm the Chief Executive.
Good afternoon, I'm Jonathan Webb, the ICB's Director of Finance.
Hi everyone, Ian Holmes, Director of Strategy and Partnerships for the ICB.
Good afternoon everybody, I'm Majid Hussain, one of the non-exec members.
Hello, I'm Carol McKenna, I'm Place Lead for Kirklees.
Hello, my name is James Thomas, I'm the Medical Director for the ICB.
Hello everyone, I'm Melanie Brown, Deputy Place Lead for Wakefield.
Good afternoon, I'm John Beale. I'm deputising for Hannah Davis for Health Watch this afternoon.
Good afternoon, I'm Harris Sultan, I'm on Next Direct Placement.
Good afternoon, I'm Kate Sims, I'm the Director of People for the ICB.
Good afternoon everyone, my name is Fatima Khan Shah and I'm here in my capacity of the Chair of the West Yorkshire Health and Care Partnership Strategic Race Equality Network.
Hi everyone, I'm Karen Jackson, I'm the Sector Lead for Community Services.
Good morning, good afternoon, I'm Peter Day, I'm Professor of Children's Oral Health and I'm also a consultant in paediatric dentistry, working at both the University of Leeds and Bradford District Care Trust in the Community Dental Service.
Jane Moore, I'm West Yorkshire LDN Chair for NHS England.
Good afternoon, I'm Leslie Stokey, I'm the Place Lead for Calderdale and I'm here on behalf of Robin Tuddenham.
Good afternoon, Nancy O'Neill, I'm here for Mel Pickup from Bradford District and Craven Place.
Hi everyone, I'm Rob Aitchison, I'm Deputy Chief Exec at CHFT and I'm here for Brendan Brown in his role as Lead for the Wyatt.
Hello, I'm Richard Vautry. I'm the Primary Medical Services Representative on the board.
Hi everybody, I'm Julie Robinson, I'm Chief Exec for Calderdale Voluntary and Communities, here on behalf of Kim Shuttler, on behalf of the VCSE.
Hello, I'm Anthony Keeley, I'm the NHS England Locality Director for West Yorkshire.
Good afternoon, my name is Beverly Geary, I'm Director of Nursing for West Yorkshire ICB.
Afternoon, Professor Anansu Chatterjee, Professor for Digital Health and non-exec member for the board.
Hello, Laura Ellis, Director of Corporate Affairs.
Great. Thank you very much. And we've now, the mics work, so that's very helpful for us for the meeting today. So as the board of NHS West Yorkshire, we're here as a unitary board here together. There are people around the table with expertise, remits, advocacy roles that they have. And I appreciate that as we go through these board meetings, and we've been meeting now for a year in public every 2 months, there will be opportunities where one colleague will ask another colleague a question, but I really also encourage you to be challenging in a professional and respectful way to make sure that we can work together as a unitary board to ensure that we are offering good services and quality care to the people of West Yorkshire. A number of colleagues around the table know that I usually say this at the beginning of our board meetings, but we do have full purposes as an integrated care system, as all 41 other systems do in the country around, and providing good quality care and tackling variations in care, tackling inequalities, which we're all incredibly passionate about around this table and across our partnership, making sure that we've got effective use of resources, and also contributing more widely to the social and economic development of our local area. Now, I know you all know that, but for me as well as chair, I hope that all our agenda items are crossing those off today as well. So as I said, our focus on topic today is around oral health and dentistry. And the reason why we've chosen this topic today is that we are a matter of weeks in now being now the commissioners for dentistry services, taking that on from our colleagues regionally and nationally from NHS England. I'm really pleased we've got colleagues around the table representing Yorkshire and NHS England. We'll be coming to them shortly. We also will be looking at our joint forward plan. We'll also be looking at our 23-24 financial plan, which began last month, as well as having oversight of our performance and our risk management. So thanks to everybody who is prepared today for this meeting, including our governance colleagues and other people that are sitting behind the scenes. It's no mean feat in bringing this all together, so thank you. So I'm just going to go on to some key standard business that we have in the meeting, and then we'll have urgent decision, reference to public questions, and then we'll get on to our focus on topic. So do we have any declarations of interest in relation to today's agenda? John.
Yes, thank you, Chair. I would like to declare that my background is I'm a retired consultant in dental public health, and I'm still, in fact, a member of the British Dental Association. And because of something I will want to briefly raise in the discussion, I am also a long-standing member and currently Vice Chair of the British Fluoridation Society.
Thank you, John. I appreciate you declaring that, as well as the expertise we're going to have around the table today, which is appreciated. Are there any other declarations for today's agenda? No. And just to reference also, we have a matrix of interest that is on our website. We had a question in our public meeting for our partnership board back in March on how this board declares its interests, and there is a document available online. But also, in addition to that, is our colleague Fatima Khan-Shah, who has been appointed as West Yorkshire Inclusivity Champion, which is a joint role between us in our West Yorkshire Health and Care Partnership and the Combined Authority in the Metro Mayor's Office. So congratulations, Fatima. I think this is the first formal opportunity I've had to congratulate you, and I know you're a matter of weeks in post as well, but we also declare that as well. Well, thank you. Moving on, we've got a number of apologies today, which we're going to note. And as we've gone around and done introductions today, colleagues around the table and those watching the meeting have heard about the deputisations that we've got today as well. And as I said earlier, we've got some colleagues coming in and out of the meeting as they fit other commitments around today. Okay, so we'll move on to item 3, which is our minutes of our last meeting in March. If you remember, we came together, and particularly we had a focus on session in Wakefield on voluntary community and social enterprise sector and the sustainability of the sector. Colleagues, do you feel that's an accurate record of that meeting in March for those who were there? Are there any corrections to be made? No, so we can take that set of minutes as approved, which is great. Should we go to the action log first before matter arising? So over to you, Laura.
Thank you. I will just highlight those that are currently open rather than going through every action. So the first open action is action 8, and it relates to how we ensure that people are at the heart of our decision making. And you'll recall that we met with young people and carers back in September and committed to re-meeting with them. So we're just working on how we will do that, and we should have more of an update at the next meeting when we'll be bringing back a report around reflecting on the last 12 months in terms of involving people. And then if I can move you down to the next page, which is action 35, which was flagged at in the January meeting from the Chief Executive's report around the work that we needed to do to understand the impact of inequalities and their contribution to excess deaths. We had flagged that for being discussed at a future meeting of the Quality Committee, but also in place committees, and I didn't know whether anyone from either the Quality Committee or place committees wanted to give an update today, and how we want to close down this action, I suppose, because it's one that's an ongoing piece of work, isn't it? It's not just a one-off.
Are there any reflections across places? Carol?
Only to say that I think Rachel Spencer-Henshaw did respond to this in the last meeting, actually, and it would be Rachel I would look to probably repeat her comments from a sort of public health perspective. So it was whether or not there was anything more we needed to do other than sort of building this into our routine business. I wasn't entirely clear after Rachel's comments last time.
Okay, that's really helpful. It's something we can ask our quality and place committees to have as a watching brief, as it were. Okay.
Thank you. So we'll move to close that one down off this action log. The next one related to our March meeting. Again, it was from a discussion on the Chief Executive's report, and it was for Kate and Carol around primary care and general practice staff. It was to do with future staff surveys. I don't know whether that's, is it Kate who's responding? Thank you.
No, thank you for this. We had a good conversation at the last meeting about the staff survey. I think there's been a few developments. I think the first one just to comment on is the Primary Care Workforce Summit that took place only about 3 or 4 weeks ago. I think it's the first West Yorkshire-wide primary care summit. There were about 120 people from all across primary care, the PCNs, the GP services, and within that day there was a lot of conversation about capturing that staff experience and survey. There is a very active workforce steering group in primary care, and indeed the 5 places have come together with some action plans. I'm attending the next meeting in June, and one of the things we will be discussing there is that staff experience agenda and how we capture that. So it's something that I've briefed Carol on as well, who's the chair of the Fuller Board. Thank you.
Thank you, Kate.
Thank you. I think the next action was also for Kate. It was around the, again, related to the staff survey.
Thank you. This was the wider point around the staff survey and some of the themes that we discussed at the last board meeting, and where do they sit really. So it is the West Yorkshire People Board. I've mentioned at previous meetings we have very much a themed conversation, and one of those pillars, of course, is we belong, and this is where I think the staff experience piece sits. So just to confirm in terms of the action, that is very much on the agenda, and of course the People Board reports through to the Partnership Board. I think the challenge, and it's one of the things we are working on in the People Board, is again making sure that our sectors who don't have regular staff surveys, that we're still able to capture that staff experience. So that's certainly a piece of work for that board, but it's very much on the agenda. Thank you.
Thank you. And the next two actions that were open were 41 and 42, relating to the discussions last time on the performance dashboard. I'll hand to Anthony for those.
Thanks, Laura. So the first one was around the experience of children waiting in A&E departments and how that might differ from the overall waiting times for the population as a whole. So we have looked into this, and I'll share a note with members of the board after the meeting. It's not public information, so I haven't tabled it. But I think the headline is that in West Yorkshire, children wait for around, well, the population as a whole is typically at the moment waiting over four hours at around 70 to 75%, and for children it's about 10 percentage points better. So in the low to mid 80s rather than the low to mid 70s. So a significantly better experience of waiting, and that partly reflects the fact that we have specialist children's A&Es in some hospitals. So I will share some more detail behind that headline. And the second action was, I think, just comments around the variation that we'd seen in data in relation to primary care, GP appointments. And I think we can pick this up in the performance report item, which will show how that variation looks currently across West Yorkshire.
Thank you. And the final open action is action 47, which relates to the delegation. So it was for Ian. It might be that we're picking it up later on the agenda, but I'll just check.
Yeah, thanks, Laura. So those profiles are shared as the annexes to the dental and oral health paper. I think there was a question about the breadth of information there and wider information on dental services across West Yorkshire, which is something we'll look to deal with, but those profiles have been provided.
Okay. Thank you very much, and that's something that we aim to do when we have a focus on topic, to give a flavour of activity and good practice going on in each of our 5 places. Okay, thank you very much. And something I just wanted to add in the follow-up from our focus on session on the sustainability of the voluntary community and social enterprise sector, we've been doing a number of pieces of work. Julie's been involved, Kim has from the sector as well. We've done a number of communications with colleagues across the partnership and in the sector. And we also held our first virtual roundtable discussion on improving commissioning and contracting, which we held on the 3rd of May, which is the beginning of work. It wasn't the answer that afternoon. And I'm really grateful to people around the table who came in during that as well, who've got a commitment to making sure that is more a respectful and sustainable way of working. So thank you for that. That's really, really helpful. We are now moving on to item 4, which is an urgent decision So this was delegated from our March board meeting, which is we can take an urgent decision as Chair and Chief Exec, and this was about the approval of the 2023-24 financial plan. And this is particularly around the timescales and the deadlines that we have. And I wanted to hand over to Jonathan to give an overview, and this would be a ratification of that decision.
Okay, thank you, Chair. So I think as we've previously discussed through the board, it's been a challenging planning round this year, both in terms of the performance and operational targets that would be required to meet for our populations, workforce challenges that have been well versed through the board, and also the financial position. We have shared the detail of the financial position previously through the board. Some of the principles that we've sought to hold dear to our hearts as we've been through the planning process have been around ensuring that our system plans are collectively owned by our partners. We use good governance, and we ensure that our decisions are tested out in terms of the impact on equality and quality. As the Chair said, we met as many board members as we could to contribute to the conversation with the Chair and Chief Exec on the 10th of May. And we did move to a position whereby we submitted a break-even plan as a system to NHS England. That plan does bring with it some significant stretch and challenge in terms of the efficiencies and productivity gains that we require across the system, and also brings with it some system risk that we will need to collectively manage as we progress through the year. That risk will be shared in more detail through the Finance, Investment and Performance Committee, and will also feature as part of the monthly returns and reports that we submit to NHS England. So that's the position that we've reached. We had, I think, a helpful conversation in terms of the context around that plan submission, about ensuring that our financial plans, our financial decisions don't deteriorate in health inequalities in the population of West Yorkshire, ensuring that we keep NHS England well sighted on the risks that we are facing as a system and the mitigations that we are seeking to put in place, and overall ensuring that the impacts, the safeguards and the consequences of that financial plan are well understood, both through this board meeting, the Finance, Investment and Performance Committee meeting, the Quality Committee meeting, and also all of our statutory partners across West Yorkshire.
Thank you very much, Jonathan. And again, as we stated in the meeting, thank you so much to you and our colleagues across finance, particularly Directors Finance, across our whole system, 5 places, and providers for working on this. And thank you to you as board members, particularly those of you who joined us last week, to have a very robust discussion about this. In terms of governance, Rob and I could have sat together and make the decision, but we believe in collective decision making, and I'm really grateful to you all for seeing the opportunities as well as citing the risks. And we've agreed together that we'll have oversight of this through our governance arrangements, including our Finance, Performance Investment Committee that AC chairs, through our Quality Committee as well, and also our Place Committees, as well as continued our communications with our NHS England colleagues regionally and nationally as well. Okay, thank you very much, Jonathan. Okay, we're going to move on now to our focus. Sorry, make the decision. Do we ratify that decision? Sorry, it's because we met last week. Are we happy to ratify that decision? Thank you. There you go, Laura. Thank you, colleagues. And we'll continue to have, as always, finance and our performance and the activity on the agenda for future board meetings. Okay. So we're going to move on now to our focus on topic. And thank you to our colleagues who... Oh, sorry, getting ahead of myself again. It's because I want to get to the dentist discussion. Very much so. Just to note, we haven't had any public questions submitted, so this is item 5 on our agenda today. We are going back and revisiting a question that Jenny Shepherd submitted for our March meeting, particularly in relation to serious incidents and ambulance performance. We have responded with the information we have available to us so far, and Yorkshire Ambulance Service are currently coordinating a further response, which we'll provide directly to Jenny, as well as put on our website again about in the way that we do in being open and transparent in relation to public questions. We can report back on that at the July meeting on concluding the response to that. We also had a query after our last March board meeting in public on the diversity of our boards, and we have also provided a response to that person, and we're following that up this week. This is something that we have worked on since December 2021 as bringing together the ICB and the board. It's something our Remuneration and Nominations Committee continued to challenge us on, which at this time last year we actually paused some of our board recruitment to learn from our Race Equality Network, and we also have a commitment through our strategic plan as well about growing the diversity of our leadership. It's work in progress. And Fatima, I wanted to invite you on your response to this query as well.
Thanks, Chair. So just, I think it's really important to acknowledge that you can't address generations of inequality in a matter of months or years. I think what we're trying to achieve in West Yorkshire is an approach which addresses some of the fundamental issues and barriers to structural racism in our organisations with some really practical and impactful action. An example of that is the inclusive recruitment that we've developed as part of the way in which we recruit and retain our staff. Another one is our award-winning fellowship, which Cohort 3 is open. So if you're watching and you fancy a new challenge, get your application in. And the other important element, I think, which is really important, is the way in which the lived experience of colleagues within our organisation is amplified and included in our decision-making. So the fact that I'm sat here, the fact that we were part of the selection process of the board, that we were part of the interventions needed to make our board much more inclusive, because that's what our aspiration was, I think demonstrates our commitment to this agenda. But what we want to do is something that is not tokenistic but addresses the fundamental issues, and there's a much more detailed action plan that I'm happy to share with colleagues if they wish to see it too. I just wanted to add a few things.
Thank you, Fatima. And we'll continue the reporting on progress through the Partnership Board. Our next meeting is in the beginning of June as well. But I'm grateful for these queries. We welcome public questions and queries, and it gives us an opportunity to share our work in progress and take on board feedback. I don't know if you want to respond, particularly having the non-exec remit in this area.
No, just sort of building on what Fatima just said. We are committed to it, increasing diversity of the board and across the layers of the organisation. We have, as you said, received a short list at the REMCOM and sort of said it's not acceptable and sent people back out to try a little bit harder. It's not going to happen overnight and stuff, but I think we are sort of looking at new ways and doing different things, because we've tried many things in the toolbox and we can't keep using the same toolbox and expect something different. So this is something that we constantly evolving and stuff. And it's not unique to the NHS or local authorities. The broader public sector have got challenges in this area and stuff. So I think the only thing I would ask or say today is if there's an opportunity to work together across the public sector to see what can we do collectively and have a joint set of actions to address some of these structural issues that exist across the system.
Thank you very much. And you've prompted me then to remind colleagues around the table that there is an ask from the Race Equality Network to share data on your workforce to help inform our ways of working within West Yorkshire. But I know Fatima and Majid, you are working together to see how we can do this across northern healthcare systems as well, which is really welcome, beginning and partnering up with Greater Manchester as well. Okay, thank you. So that's public questions, and actually now we have a full complement, I think, of people to get onto the thing I'm really excited about talking about today, is about how we can work together to improve our oral health and dentistry services. So colleagues, thank you very much for contributing to the report. I know a number of people around the table as well as behind the scenes have contributed to this. When we have a focus on topic, we want to understand the context, we want to understand the barriers, the opportunities, the ways in which this board can support things to happen in the short-term and immediate future, as well as any long-term ambitions that we have. In our risk appetite, we want to be bold in certain areas, and this might be an area we want to think about in doing so. And as I said earlier in the introduction, we have the delegated commissioning of this service for a matter of weeks now within our financial year. Our colleague Ian, who's going to introduce the document in a moment, has been keeping us informed as a board over a number of months now, and this feels like a key moment really. So Ian, would you introduce the document as well as colleagues around the table, and then we can get into a discussion.
Yeah, thanks very much, Cathy. And so Peter, Emma and Jane have introduced themselves. So there's for the late arrivals or the people who arrived on time but slightly later. Sandra, do you want to say who you are?
Good afternoon. So my name is Sandra Whiston. I'm a consultant in dental public health with NHS England.
So I am a dentist by training, but I'm a specialist in dental public health, and my role is providing that specialist public health input, primarily to NHS England, but I also work across the system, and within our dental public health team, I lead on West Yorkshire.
And Joe?
Hi, I'm Joe Hendren. I'm a dentist. I work in a largely NHS dental practice in Wakefield. I am chair of the Wakefield Local Dental Committee, and I'm also here representing the three other local dental committees covering some 200 practices across West Yorkshire. I also sit on the British Dental Association's General Dental Practice Committee on the executive subcommittee of that.
And Jason?
Yeah, hi, I'm Jason Atkinson. I'm a dentist also in primary care. My role is Associate Postgraduate Dental Dean for Workforce Training and Education, formerly Health Education England.
Thanks. So we've hopefully got the right expertise around the table. So it's an important conversation, this. We've got an hour to talk about dental and oral health in West Yorkshire. And I think it almost symbolises the importance of it, the fact that we're having this conversation, as Cathy said, immediately after we've taken on delegated responsibility for the commissioning of these services. So really grateful for the time on the agenda and the conversation that we're about to have. We'll assume that you've read the paper, as ever. You obviously had it a week ago, so plenty of time there. What I'll do is I'll summarise the key points that I'd like to draw out for the conversation. And the first thing to say is that we absolutely recognise the challenges and the issues in these services. We've heard consistently from Health Watch over years that this is the #1 issue for people living in West Yorkshire. We know it's hard to get access to a dentist. We know you have to wait a long time for community dental services. We know there's inequalities in access across our region, and we know that has an impact on people's mental and physical well-being, as well as knock-on impacts on other services across West Yorkshire. So we absolutely recognise that, and the reason we're having this conversation is that we want to do something about it. What I would say, though, is that those challenges are long-standing and systemic, and they probably reflect 20, 30 years of policy and practice. And so while I think we're committed to this agenda, and as Cathy says, we want a bold risk appetite on this agenda, we need to be realistic about what we can do over what time frame, I think. And hopefully the paper starts to get into the recommendations and the work that we want to do together to hopefully make improvements. In terms of the recommendations, we've got 6 of them there, which hopefully speak for themselves. The first is around oral health and prevention, and there's a point in the paper there that's really important, is that poor oral health is, in the majority of cases, preventable. There's a lot of work happening across local authorities in West Yorkshire on the prevention agenda. We've shared 3 really good examples, I think, from the work that Peter's done on oral health prevention programmes for younger people. And I think there's an opportunity working through ICSs, working in partnership with local authorities in a more integrated way, to learn, share, do work together and really scale up the good practice that we know is happening in places across West Yorkshire. When we're talking about oral ill health prevention, it's difficult not to have a conversation about fluoridation as well. And you'll know that as part of the Health and Social Care Act in 2022, the responsibility was transferred to Secretary of State in terms of water fluoridation. And with your support, we're keen to get into a conversation with the Department of Health and Social Care around the opportunities to do that in our region, recognising the complexities and the time it would take to do that kind of work. So we'd like your support to promote the work on oral health prevention, work more closely as a network across the system to share, learn good practice and scale up work where it makes sense to do so. The second recommendations relate to things that we want to do almost within the constraints of the national dental contract that we think will make a difference and improve things for people in our region. The first one is around flexible commissioning. And the idea of flexible commissioning is where you take a proportion of the contract value and you agree with local dental practices to use that resource differently and use that resource in a more targeted way to meet needs of local people. As a region, I think we've been pretty successful in terms of flexible commissioning. We've done quite a lot of it. It's currently being constrained to about 50 odd practices, so about a quarter practices across our region, and a 10% contract value. But what we hear from LDCs and from other colleagues is that this is a really, really good, important and powerful scheme. And again, if we're taking that bold risk appetite, it's how we work together to potentially scale some of that up based on practice that we know that works well. The second part of it is around additional access schemes. And one of the things that's important about dental services that I didn't know when I got more involved in this is that we don't spend the full value of the dental budget in West Yorkshire, and we don't spend it because we don't have the capacity to deliver the full value of the contract. And because this service has been commissioned by NHS England in the past, the majority of that underspend has been drawn back into NHS England and not used for dental services. So I think in the past we've used about 2 million of an underspend to support additional access schemes. Conversations with Leslie have suggested that we think there might be an additional £4.5 million, which may be available to us this year. Projected underspend, that if we actually get ahead of it and plan to spend that money now, we can probably make quite a big difference in terms of access and needs in our region. So again, with the support of the board, what we'd like to do is empower the team to develop a more detailed plan for how we might spend that £4.5 million at the start of the year, recognising that things may change in the year. We might have to pull back a little bit, or if we're predicting additional underspend, we might want to speed up and accelerate some of those schemes. But I think the principle of ensuring we spend the full value of the budget well this year is a really important one, and one that we'd like the board to support. The next sort of set of recommendations really are around workforce, and we don't have a workforce plan for dental services for West Yorkshire. We believe there's opportunities around changing skill mix, around international recruitment, around supporting retention of dentists by giving them jobs that give them job satisfaction. And what we're really keen to do is develop a sort of a slightly longer term plan, working with people like Jason, Joe and other colleagues, so that we've got a clearer plan for recruitment and retention. We'll never spend the full value of the dental contract unless we've got the capacity to do the work. And so working differently to deliver that, again, is important. And then the final two recommendations are more really about the commissioning capacity within the team that we've inherited. So as we've discussed previously, we've received a full transfer of the commissioning resource from NHS England. It's a precious resource, but it's a very small resource. And if you look at the number of the contracts we're managing, the scale of the challenges around dental services that we've heard, there probably isn't the commissioning capacity there to do the job to the level that we'd like it to be done. This absolutely isn't about capability or will. It's about number of people doing the work. And particularly if we're keen to expand access schemes, look at flexible commissioning, we're going to need the staff to support us to do that. So the fifth recommendation is around supporting expanding the team by 6.5 full-time equivalents across Yorkshire and Humber. So that's 2 and a bit in terms of the West Yorkshire team. And the second part of it is about how we use teams in places so that it create greater connection between the commissioning of the work and the work at West Yorkshire with the sort of the integration, the place-led work that we're doing in our partnership anyway. And we look at that as part of the work that we're doing around the West Yorkshire operating model. So those are recommendations 5 and 6. So like I say, I'm really grateful for the input we've had from the folk around the table who know a lot more about this topic than I do, although I'm learning quickly. And what we think we've got as a package of recommendations there, that while we recognise that there's some real constraints to getting this where we want it to be, the things that we can do now that we believe will make a difference. So I'll pause there and I'll just ask my dental colleagues whether there's anything else that they want to add before we open it up to further conversation.
You are really welcome to share your expertise, and I suppose to share with you in terms of our format of meetings, when we looked at primary care and GP services back in November, it was great to have GPs in the room as well to share their views. So we really invite you in to share with us what's working and what could be improved upon. Joe?
Yes, we've been working with NHS England for the last probably 4 or 5 years developing this flexible commissioning, and really Yorkshire and Humber NHS England have been a vanguard in trying to look at alternative ways of delivering care within a fairly restricted national contract. And I think, it's a journey, but I think we've only really got into second gear. and we've been really waiting for the ICBs to become established so we can start to move things into overdrive. Having said that, the flexible commissioning really is considered as being a bit of a sticking plaster to repair the fault of a dental contract that came out in 2006 that's been denigrated by certainly the Health Select Committee in 2008 and is probably going to be denigrated by the current one following a recent inquiry. But certainly LDCs are very keen that we do try and keep the money that's allocated to dentistry within dentistry for the good of the patients of the West Yorkshire area.
Thank you. I don't know if other colleagues want to share. Yes, Emma.
Thank you. I think I would just reflect that the colleagues that I have around the table, I might be Head of Service for Dental Commissioning and have worked on this agenda for 4 or 5 years and still have a lot to learn. I have to say it's an ever-evolving agenda. I think it is testament to the fact that we've got so many clinical colleagues around this table. The projects that or the initiatives that we're asking for support for have been delivered because we have got good engagement and commitment from our clinical teams and our providers in the system. It isn't just primary care. We've got our services such as Locala and other colleagues who deliver services and are really willing to test some of these things. And that's been the expectation and the delivery. And I'd be really, really keen for us to continue with that. At a time when things have been incredibly challenging. I know COVID was difficult for us all, but for dental services particularly because of the closures and the recovery, it was a really testing time, and yet I still had so much commitment from our colleagues to try things out. So the fact that we're able to say to you today, our initiatives have seen some positive outcomes, it isn't because of that commitment. So I hope that we can continue with that. And of course, not all our colleagues around the table to express those views as well. Thank you.
Thank you. Jane?
Yes, the LDN engages with all stakeholders across West Yorkshire, not just primary care. LDCs are represented, Health Watch represented, Ian sits on the LDN as well. And as Emma said, we also have representatives from the community dental service and from secondary care. So it is a really important network. I've worked on all the initiatives that we're asking you to consider today. I work as part of the commissioning team, and we are very, very stretched, I have to say. So that's an important thing. Dentistry is extremely important for patients, and we've seen the service decline and decline and decline, and it has never really been considered alongside general medical practice, which I feel it should. And I'm really hoping that the Integrated Care Board will be truly integrated and support NHS dentistry in the same way that it would support pharmacy, medical practice or optometry. Thanks.
Thank you. I don't know if other colleagues, whether Peter or Jason, you want to say anything before I open up to the board? Not to put you on the spot.
It's fine. So, yeah, my focus obviously is on workforce training and education. And that starts at the undergraduate level, where we recruit our dentists from, and how we integrate their training into local areas. So one of the kind of areas in the recent Advancing Dental Care Review is to create centres for dental development, which are placed geographically in areas of high need. And we train undergraduates in those areas, and then we follow that up with foundation training posts, where we hope they will actually lay their roots, because actually most dental students tend to stay around dental schools and don't move past maybe 5 miles. That's where they want to be. So part of the work that we're doing is looking at redistribution of training posts, and then how we can support and encourage people to remain in that area. And flexible commissioning in the short term can do that by taking them out of the kind of treadmill of a UDA approach. And so some of the areas that we're looking at in developing are training pathways for people post-foundation training, where we upskill these people to become more able to deliver higher sort of levels of service in primary care. So the level 2 practitioners that Workforce Training and Education have developed for paediatric dentists, and we can extend that to minor oral surgery and so forth, so we can move some of the services out of secondary care into primary care. My view is always about education. Actually, people will stay in a place if they can see a career, if they can see a structure of that career. And I think we're at the early stages of developing that structure in primary care.
Thank you. Peter and Sandra, I don't know if you want to contribute. Peter.
I was just going to pick up very excited to be here. I think the appetite is really exciting, and the opportunity for integration across the area. So I had two areas at two ends of the different. So in my clinical work, I'm the dentist taking out teeth and for children under general anaesthetic, and there are certainly some challenges in that space around access to operating lists. I think because much of the data is actually often held not in acute trusts, there is sometimes that data isn't seen, and so the waiting times is often only seen through hospital waiting, and that's not always held by the acute trusts. And certainly if the board does have sight of that across the piece, and I think that would be helpful to see where the variations in service are. I think, unfortunately, for some of the access to those theatre lists, often the children and adults with the greatest vulnerability are waiting the longest. And often the opportunity to those lists is not always appropriate. And if we believe in reasonable adjustments, waiting until Friday afternoon at 4 o'clock for an autistic child aged 4 to their operation is not really appropriate. So that's one end of the spectrum. The other end of the spectrum, again around integration across the patch, is around how we look to, with all the challenges around access to dental care, there are some really valuable opportunities around using the wider workforce, such as health visitors, schools, early years workforce, and it's how often the benefits and improvements in oral health will improve the dental budgets, but how do we incentivise our wider colleagues to support those activities rather than it being on a grace and favour?
Thank you. Sandra, is there anything you want to say? And then board members, if you've got any questions or comments, then we'll start taking a list.
Thank you. Just wanted to echo some of the comments that have already been made about, the ICB has taking on the responsibility for dentistry does open up real opportunities for that integrated approach across the wider system that Jane's alluded to, especially since so many of our oral diseases, they are preventable, but they also share common risk factors with many other diseases that you will discuss frequently, I'm sure, around this table. Good oral health does have a massive impact on an individual. It's not just the health of the teeth. It has impacts on their health and well-being, both physically and psychologically. And I suppose part of that is, Ian alluded to the homeless pilot that we ran in Leeds, and when you look at the evaluation of that, the qualitative data we got back, the impact on those individuals is just phenomenal, and it helps these individuals turn their lives around. I think that's probably all I want to pick up. I could keep going on, but Ian did such a fantastic job. We've trained him well already in terms of his understanding of how, it's not just access. We do need to run. If we're in this for the long term, for the benefit of the population of West Yorkshire, we do need to take prevention seriously. Thank you.
Thank you. And in these focus discussions we've had, as I said earlier, we look at short-term, medium-term and long-term aims, and we can see in the document that that's been outlined. I've got a number of people who want to speak and comment and ask questions. We've got AC, Fatima, Richard, Nancy, Majid, if you also want to comment. Harris, but John, I wanted to come to you first as our expert and Healthwatch representative, and also some of you are part of this today, but also for our minutes for members of the public to know that we had a board engagement session this morning with colleagues from Healthwatch across our 5 places in West Yorkshire, where they shared feedback with us from people using dental services and particularly poor experiences, very poor experiences that they've had, and this complements and works with the reporting that Healthwatch has shared with us over many months, if not years, on this issue through their insight reports, which we're really grateful for. So, John, I know you're representing Healthwatch today, but you also, due to your expertise, I don't know if you want to comment first, and then we'll go to our board colleagues.
Yeah, thank you very much, Chair. Thank you. Can I start, like other colleagues, in thanking Ian for his paper? He's done a truly tremendous job actually pulling that together, and I'm sure everyone is most grateful for that. I'll just say 4 things, some of which came out this morning. Firstly, we've heard about outreach, and particularly with relation to foundation training, the postgraduate period. I think it's very important, and the Leeds Dental Institute does do some outreach for dental students where they go into areas which are perhaps under-dentisted. But I think it's not just a matter of addressing inequalities, although it's very important to go out to those sort of areas, but actually in dental school they're in a very protected environment, and they're going to go out into the big wide world, albeit in foundation training under some sort of supervision. But I think it's the earlier which we can get students to get some experience of actually working in the community, the better. It's a win-win situation, addressing inequalities, but also improving the educational experience of the dental undergraduates. I think that's an important thing. Secondly, Ian addresses the workforce issue and talks about a workforce review. That's great. Really, ideally, it ought to be part of a national review of workforce. You know, we need to know how West Yorkshire fits into the rest of the world of dentistry. That might come on the cards soon, but it isn't, as far as I know, at the moment. But it would be good if it was. But it's not just looking at numbers. It's looking about how we use the workforce. And I look at colleagues from the medical profession across the table. They are very good at having built up a team of people with different expertise doing a different part of what a general practice provides. We're not very good at dentistry. I mean, we do train dental nurses, and we train hygienists to do scale and polishing, and we train therapists to do simple fillings. And then the therapists go out into practices and they spend a lot of their time doing scale and polishes, not doing the fillings. Let's use our workforce to the utmost of their capabilities. So I think we need to look at how we use the dental team and not just how many of the dental team we have. And we've heard about prevention, and you know, Peter does an enormous amount of work working in schools, and that's great. But we also need, and it's mentioned to some extent in the paper, we need to plug in to what other health professions, and indeed other professions like the teachers and the media and so on, are doing. The mouth is part of the body. We're not just looking at the teeth. We're looking at the mouth as a whole and the body as a whole. So we need to work with health visitors talking to the mothers of young babies about how they look after their children's teeth, with midwives about talking to the mothers about, you know, not giving their very young babies sweetened bottles at night, for instance. So we need to use the whole of a much wider team. It's part of the risk factor for dentistry. It's exactly the same as for, you know, diet is part of health education, part of health improvement, as well as dental health. Dental health is just one little bit of it, so we need to make sure that it's integrated. The one thing which is specific to dentistry, and I did declare that I'm the Vice Chair of the British Fluoridation Society, is water fluoridation. I, as part of my PhD, looked at the effects of water fluoridation in Birmingham, and I saw the benefits. And then a bit later I was appointed as the area dental officer for the city of Birmingham. And I was also an honorary senior lecturer at Birmingham Dental School. We had to send our students from Birmingham Dental School to Wolverhampton because they had much more decay out in Wolverhampton, which was unfluoridated, compared with the kids in Birmingham. Sadly in one way, but rejoicing in another way, weren't able to do that for all that long because Wolverhampton had the audacity to go and fluoridate their water as well. So there was no point in sending the students to Wolverhampton. But it's about time the kids in Leeds and Bradford and Calderdale and Wakefield and Kirklees had the benefits which kids in Birmingham have had for a long time. And it's not just children. We tend to concentrate on the children's oral health. But anyone with their own teeth, it won't affect you if you've got dentures, I'm afraid. But if you've got your own teeth, you'll get some benefit. And the longer you've lived in a fluoridated area, the more the benefit would be. And lastly, I just want to mention the community dental service. I might be wrong, but my impression is that the community dental service in Leeds, and I suspect if it is true in Leeds, it's true elsewhere, is underfunded. We don't have any benchmarking. We don't, as far as I'm aware, compare the size of the community dental service, which, by the way, is basically a special care dental service. It's for those patients who are not, for various reasons, terribly suitable for treating in general dental practice. Children with autism, people with learning disabilities. Practices often struggle with such people, and in terms of the way dentists are paid, they can't afford to spend a long, long time caring for someone who needs not only specialist care in terms of expertise, but also a much longer period to treat them. I think that Leeds, compared with, say, Manchester or Birmingham, is underfunded, and I think it would be useful to actually do some benchmarking to see how Leeds fits into comparable, and that's the other parts of West Yorkshire as well, fits into what's going on elsewhere in terms of the funding, because I think that some of our special needs patients, those with protected characteristics, are not always getting a fair deal. I might be wrong, but if I am, that's fine. If I'm right, we need to address that and give them a fair crack of the whip.
Thank you very much, John. That's incredibly helpful. And again, as colleagues know, but if you haven't seen it, we've got a full report from Health Watch, which I'm trying to find in front of me. We particularly have a letter from a dentist sharing ideas on ways in which they could offer services to children, and we also have a number of quotes and insights from people using services across the area. So, John, your expertise as well as your perspective from Health Watch is really, really valid and very helpful to us. So we have a list of board members now who want to comment. So we go AC, Fatima, Richard, Nancy, Majid, Harris and Karen. And if I have missed you off the list, then please let Laura and I know, and Kate. And we'll come to you now, and we've got around 20 minutes or so. So AC to you and then to Fatima.
Thanks a lot, Kathy. Thanks, Ian, for the paper. And I think quite a bit of what I was going to say has been covered in sort of various conversations with colleagues who are much more informed in this particular area than I am. But however, I have a couple of quick questions to Ian. You mentioned something around sort of improving retention, and we in the board engagement session we had a sort of conversation about capacity and commissioning. So the flexible commissioning approach that we are going to consider will improve that retention challenge?
Yes, I believe so.
Okay.
I think there is, and Joe might want to come in on this, I think. We had a conversation with the LDC network a couple of weeks ago, and I think, do you want to just switch yourself off, AC? Sorry. And I think dentists leaving NHS work to do private work, part of that has been around the sort of the structure of the contract, so things we can do to improve that, and flexible commissioning is an example of that, is something that might help with retention of dentists and keep them in NHS services.
Yeah, if I could come in there, Chair. So this UDA contract that was introduced in 2006 was using values over a period of time, 2004, 2005. We've moved on since then. The dentists have moved on since then. We've all got older, mature. We've got younger dentists coming in who've been taught slightly differently, slightly more modern procedures. And the current way of trying to achieve your UDA targets has become increasingly difficult. And the initial thought was, well, if you have a throughput of patients, then you can take on, as patients die or move to a different area, you will take on new patients. But with the reducing investment in dentistry from central government, the UDA value, the value of the contract, hasn't risen in line with the cost of living. So dentists have lost somewhere in the order of about 35% since 2008. And so to take on a new patient who's got increased needs on a restricted contract where you're only paid a limited amount to get somebody reasonably dentally fit is just inappropriate. So this is why dentists are leaving. They don't feel that they're valued. They don't feel that they're remunerated for the effort and the skills that they have, and they feel that that's better in private practice. So in order to, and as practices struggle to make these targets year on year, more and more money is going back in clawback, not to be historically not spent in dentistry thereafter, apart from a small amount. So it's important that we find this sticking plaster, which I referred to earlier, of some way of trying to give the dentist confidence that we can still stay within the NHS system, delivering NHS care, but delivering it slightly differently, delivering it with a more emphasis on prevention, which Ian's alluded to and Sandra's mentioned. And that's what young dentists are taught. They're taught more about prevention rather than to drill and to fill. And if we can show that that is the future, or certainly the near future, hopefully that will aid retention.
Yes, AC, what's your next question? Then Sandra, if you want to come back, and then we'll go to some other colleagues on comments.
Not a question. So I think that's really useful. Thanks a lot, Ian, for that. So I'm assuming that this will translate into a plan of action, which it will be useful to see that plan of action alongside with it mapped to the metrics over a 3 to 5 years plan. And sort of that's something that will come back to the board at some point, I'm assuming?
Yes. I mean, I think the immediate thing for me is to spend the £4.5 million as well as we can this year and have a plan to do that, working with the experts that we've got. I think certainly in terms of the workforce challenges and the skill mix issues, a 3 to 5 year plan would make absolute sense. I think it's doing the right plans on the right geographical time period, I think.
Thank you, which includes the recommendation on a people plan that links in overall with our West Yorkshire people plan. Sandra, do you want to come back in, and then we'll go to some other board colleagues?
Yes, please. Thank you. It was about the picking up about skill mix and flexible commissioning. One of as well as flexible commissioning, when we designed the programme, was meant to drive both access and delivery of prevention. Again, supporting what Joe's already said about, our younger practitioners. They're trained to deliver a preventive ethos, which then they get into practice and the contract doesn't permit them to deliver. But it was also underpinned with the idea of introducing genuine skill mix into dental practices, which has been talked about for many years, talked about sort of mirroring what, as John again alluded, has gone on in GP land, whereas in dentistry there's never been that incentive for them to develop skill mix in that same way. And so what flexible commissioning and involvement in that programme does is it allows them to develop the whole dental team. Each practice has an oral health champion who is generally a dental care professional, and by that wider team leading that prevention agenda, that does actually free up more time for the dentist to do more of the type of treatment that only they are qualified to deliver.
Thank you. We're going to go now to Fatima. We'll take a group of comments and questions. So Fatima, Richard, then Nancy. Fatima.
Thanks, Chair. So, Ian, really appreciate this well-formed paper. As a former chair of Health Watch that was having this conversation about 8 years ago, this is the first time I've got a bit of hope, so thank you for that. I really welcome the aspiration that as West Yorkshire we continue to be ambitious for our people, and one element of that is making dental everyone's business. I think there is something about how we utilise the elements of personalisation on this and develop people's skills, expertise and capability to take ownership of their own healthcare as well, because I think people feel really out of control at the moment because they don't know where to access it or what they need to do, and there is programmes and work in the system that can really support this. I also wonder, and reflecting on the engagement session we had this morning, whether we're using the right stakeholders to amplify some of these messages. So we met this incredible volunteer called Megan, who was a sixth former advocating some really important messages about dentistry, and she's connecting with a whole group of people that maybe we need to connect to but wouldn't because of just who we are or what our background is. So it'd be great to use those innovative opportunities. I also think from a strategic race equality network perspective, we can't lose sight of the fact that deprivation is only just one factor about people's access and experience of dentistry. There are also associated costs for people that utilise these services that are part of the NHS contractual budget. So is there an opportunity for us to be as innovative as we possibly can be and be mindful that if you're choosing between heating and eating, you might also be choosing whether to access a dentist as well. And then the final point is to be really mindful of the fact that this is a cradle-to-grave issue. So we know from carers' perspectives, for example, that if they're caring for people that are housebound, their access to dentistry is really challenging too. And it's important that when we're sharing information about access to NHS dentists, that there are people that are able to support colleagues or carers that are helping people at home as well that can't reach them.
Thank you very much. That's really helpful. And that chimes in the paper about services for people with the greatest needs and a life course approach. And a point from Peter earlier, having proper oversight and insight of what the waiting list looks like as well. Okay, thanks, Fatima. Then we'll go to Richard, then Nancy. Richard, Nancy.
Yeah, thank you, Chair, and thank you, Ian, again for the paper. I welcome it and welcome the recommendations, which I support. I think fundamentally we need a new dental contract nationally, and whilst I recognise that we have a role to play locally, we also have a role to play in lobbying NHS England, politicians and others who can make that decision and put the necessary funding into a national NHS contract. And I agree with Jane, we need to actually prioritise the NHS dental service in the way that government and ministers prioritise general practice in ways that they do. So I think that's fundamental to what we do going forward. I think we obviously then need to work within the constraints. I agree very much with John's comments about the need to focus on the community services and other services which are excellent, but underfunded, and we need to support those properly. And also your comments about fluoridation. That is something that we can potentially now start to work on. I would like to see much more information about what the implications would be, how we achieve that, what are the limitations around that. And I think that's something that we could work on locally to try and address. Particularly if Birmingham can do it, then Leeds can do it, Huddersfield and Wakefield and Bradford can do it. So I think we should be doing that too. I think the other thing that would be really helpful, many colleagues will realise and know that many patients resort to their GP services for dental advice, often inappropriately, and GPs would often direct patients to dental services in the hope that they might be able to access them. One of the things that would be very helpful locally is if we could issue joint guidance to our GP colleagues and practices about how they handle those situations, because I suspect many patients are receiving antibiotics inappropriately or treatments inappropriately because that's all that really the GP can potentially do in that situation. And I know that there has been national advice put together by the BMA and the BDA around how to deal with patients who are presenting in different bits of the service. And I think if we could maybe look at that and revise that so that we've got something locally, I think that would be extremely helpful. And then, and I think has been alluded to as well, in part to try and address health inequalities, we have at the moment, I suspect, many people who are cherishing their NHS service, going regularly with probably good dental hygiene, and many without the access to dental services with much less or good dental hygiene. Whether there is any way we can maybe extend the period of annual checks or biannual checks that some people get so that others can actually get in and maybe have one check a year at the expense of those who are going every 6 months or 3 months.
Thank you, Richard. We'll take some more board comment, very practical and very helpful as always. I'm going to ask Rob to comment later on some of those points, including on lobbying. But we'll just go now to Nancy, take your comments, Nancy.
Yeah, thank you, Chair. I think you'd expect me to say Craven. So the paper references Bradford and West Yorkshire, but we do cover, I think the boards need to acknowledge that. Secondly, I was going to pick up the fluoridation point's been well made. Welcome the Secretary of State rather than local authority. Action for that. I think we need to leverage that as much as we can. And I think there's something about looking at the full spectrum from general dental services through community services, specialist services, and recognising the difference between urgent and emergency. If we got the balance right between all of those 5 different areas, and can we look at that in the round? And I know that that's a challenge, but I think it's the totality. People flow through those. And I think finally, just the comment around that flexible commissioning contract, that 10%, and I know the paper reference is doing more and targeted into the more deprived areas, but I suppose my question is about the pace at which we can do that, because there's a clear correlation between deprivation and oral health and oral well-being.
Thank you very much, Nancy. We'll go to Majid, Harris, Karen and Kate. And to help other colleagues prepare, I wanted James and Bev, whether you might just reflect on quality of service as well, and how we might work on that together going forward. It's something we heard from Health Watch today about some people do have dentists, but sometimes are concerned about quality of care. We'll come to you in a moment. Mel, I've just seen that you put your hand up as well. So we'll go to Majid, Harris, Karen next. Majid.
Thank you. Just a few quick things. The first one is a note to self. This space in terms of health and social care is crowded, so to make sure that dentistry stays in there and other conversations and stuff. So that's the first thing for me. Second thing, we spoke about a dental workforce strategy, and alignment is really, really important with the overall workforce strategy, because there'll be a number of strands within there, and it's really important that we don't create multiple work streams around the same thing. So just about that sort of connectivity. Disappointing around the data, that we haven't got sufficient data to sort of really take the oil to the squeak. So that is really, really problematic. And I'm just thinking about this 4+ million underspend. That how are you going to make sure that disabled people, disadvantaged communities, protected characteristics, that what we do doesn't further exacerbate inequalities? Because by opening up access, it doesn't mean that those people who are furthest away from the services are going to get to it. It might just widen it further. Last point around prevention. We've got some amazing community groups operating at grassroots levels within this sort of work. It'd be really, really good to see how they are getting engaged and involved, particularly around prevention, education, supporting people with toothbrushes, toothpaste, etc., etc. So there were my 4 or 5 points.
Great, thank you very much. Imagine this is something also you're encouraging us to make sure as we make decisions. Ian's led us on a session back in February on strategic decision making and choices. It's about making sure that we're not increasing inequalities. That's not our job, is it? It's the opposite of what we need to be doing. Okay, thank you. Harris, then Karen, then Kate.
Just a few points. First one, the environment. As inhalation sedation procedures, dentists commonly use nitrous oxide. As an ICP, we've changed the gas we use for anaesthetic procedures. Nitrous oxide is 265 times more harmful to the environment than 1 pound of carbon dioxide. Does us taking on the commissioning of NHS dentistry mean that we should transfer it more to be more environmentally friendly to align to our values? Second point on future dental workforce. I was talking to some 5th year dental students, and they were saying we need to give more incentives to dental graduates to go into NHS dentistry opposed to private, as relying on goodwill isn't enough sometimes. So it's easier for them to go into private, as the NHS doesn't pay a lot for you to perform difficult treatments, whereas privately you get to decide the cost for yourself. And also on the point of looking at dental hygienists and therapists, in medicine we do it really well. We've looked at allied health professionals for years and how we've had multidisciplinary teams and how it's worked, given all sorts of apprenticeships coming out of 6th form. So how can we do the same for dentistry? And a final point of, if we're having oversight, what type of metrics and data will ICB members have access to maintain this oversight?
Harris, thank you so much. Great questions as always. So I think the point on workforce, the point on looking at the oversight links with AC's question on the work plan as well, which Ian has agreed to. We come back to apprenticeships, but dental colleagues in the room, Harris's first question on an environmentally friendly approach and committing to what our climate change agenda. Am I putting you on the spot, or can you answer that now, or can you come back to us on that, please? Rob?
I was just going to wonder if we just use the same approach we do with anaesthetic gases for all procedures in hospitals, which is we've moved to less environmentally damaging substances.
Sandra?
I frequently find myself saying that dentistry is different. Many of our anxious children are only able to receive dental treatment using what we term inhalation sedation, which relies on nitrous oxide. And there are already instances around the country, I believe, where our community dental services where the community dental service is hosted and provided by an acute trust, who are coming up against barriers in terms of the trust have adopted a no nitrous oxide policy, and now they're caught between a sort of rock and a hard place in being unable to deliver a significant proportion of their very specialist care.
Thank you. Yes.
Just to point out that actually inhalation sedation is only given by very few sites if you look at dentistry as a whole. So within the hospitals and within some CDS clinics, but it's quite a small proportion. And there are quite a lot of initiatives looking at making dentistry greener, actually, that are going on at the moment. I think BDA have got a programme on it at the moment. Joe, do you know a bit more about that?
No, not in any real detail, but there is obviously increasing concerns for the amount of waste that we generate with our cross-infection control and wrapping instruments and the use of non-reusable instruments. But certainly getting back to the inhalation sedation, I agree with Jane. It's a very small number of sites that deliver this. It's not generally applicable in general practice. It's not normal in general practice to deliver this, but it is an essential tool in the armoury to be able to deal with children who are unable to tolerate even the simplest of procedures, where a full general anaesthetic would really be way too risky. So we're trying to weigh up what's good for the environment, but also what's good for the patient. And I see both arguments, but I think this is something Jane alluded to earlier, that dentistry isn't represented on integrated care boards, and this is one of those crossovers where a dentist or somebody with dentist background will be able to bring some insight into these decisions that trusts are taking. But it's something that the Health Select chair asked one of the ICBs in his dental inquiry, why are there no dentists on the ICB, and what kind of value do you think the dental profession make of that? So I'll leave, and that's my rant over. Sorry.
Thank you very much. Well, we do have Richard Bautry here representing the breadth of primary care, so we are doing our best there, and also through this session today. I don't know if other colleagues, particularly Jason, want to pick up on that continuing theme we've had of ensuring students are coming into the workplace, having a positive experience of the workplace, and also that point on apprenticeships and incentives to bring people into the NHS as they qualify.
Yeah, it's quite a lot to cover there.
I know.
Certainly within foundation training, a lot of the kind of initiatives that have already been mentioned do occur. So we do have foundation dentists working with healthcare workers. We do have foundation dentists going out of their practices to engage with communities, to get experience there. We do have foundation dentists working in schools. Especially we've got a project going on in Batley called Raise in Yorkshire, where we look at sixth formers to try and encourage them not just in dentistry but into other healthcare professions where traditionally they don't normally feel they've got a place. And I think that sort of goes to recruitment right at the very heart of the problem, is actually where do we get our dentists from? And when you look at nationally, where perhaps over half the undergraduates we train in this country come from London, and they come from areas perhaps that are quite well off, we need to start to refocus where we actually train and get our healthcare professionals from. Because actually they'll go back to those roots, they'll have connections to those communities and understand those communities. There are apprenticeships that are starting off now in DCP nursing. There's also in therapy apprentices that are just starting off. And certainly what's exciting is what's happening in medicine, where you're looking at apprenticeships that start off going to become a GP. And that could, again, you still have to have the same training, but you actually start much younger. And there's an opportunity to do that in dentistry as well. So I do think that would help some of the recruitment issues and perhaps retention in the areas that we need them to go to. I think as a sticking plaster, the flexible commissioning can help support our foundation dentists going into practice, so we can actually replicate the experience they have in foundation training, where we show that dentistry can be done in different ways. Because as the board may not be aware, there is no pressure on foundation dentists to generate UDAs. They're not there as a UDA machines. They're there to train, educate, and deliver care to patients. And the flexible commissioning component takes away that UDA stress, if you like. And certainly for people that are starting off, a couple of the kind of private corporates have offered salaried structures, and I've linked that to flexible commissioning, and a lot of undergraduates, a lot of foundation dentists value that. They don't want to join a UDA treadmill. They want to work the way they've been trained at the undergraduate level, the way that we try to get them to integrate into primary care, saying this is possible. And then as soon as they leave foundation training, they hit the UDAs and they realise it's not possible because of the constraints. They've got to earn a living, and the way they earn a living is not through prevention, it's not through engagement, it's not through tackling complex patients, it's through churning out basic widgets. And that's the kind of the short-term break, if you like, that this board can make tomorrow by expanding the flexible commissioning programme.
That's really helpful. Thank you very much. It was really helpful to hear about local examples. We're really interested in pockets of best practice in a place or a community, and how we as an ICB can encourage that practice in other places and communities as well. So all those case studies are very helpful. Thank you for answering that question. Frank, our colleague Frank Swinton, who has worked on our overall climate change and sustainability strategy that was signed off at our March Partnership Board, maybe someone to come in and support and respond and make sure that this plan is aligned with that plan. And I suppose that's the challenge in bringing it into an existing system and with an existing strategy to make sure that this aligns with everyone's priorities and needs. Okay, we've got 15 minutes left, and I still want to invite some other people to come in. So we've got Karen, Kate, Mel, James, Bev. Karen.
Thank you. So my role in this room is to represent my colleagues in community services who provide community dental services for those children and adults who have specific difficulties, maybe learning disabilities, autism, or just they're frightened to death. I think the point that was made earlier around the size of that waiting list being potentially hidden and not seen as much as it should be is really important. And we're doing some benchmarking work in our Community Services Collaborative to look at all of our services. I think it's great that Ian took time to include, and you all took time to include community dental in that, and the work that's done in there, having witnessed it, is quite extraordinary. I think we have to work together. So I know I'm working really closely with our acute colleagues to understand how we better get on the list, and the theatre list that we have time allocated. We do take time and effort to try to prioritise our lists for those in most need, not just those who've been longest on the list, but the lists are significant. And I think the other really important thing worth noting is that there are codependencies. So the last time I was in our community services dental clinic, there was a child there who needed some surgery for a cardiology issue, but couldn't have that until the dental issue was resolved. And so this is not as simple as it's a child or an adult with learning disability who needs their teeth. There are other things that are presenting dependencies as well, and I think we have to bear that in mind. And I welcome the question there about have we got this funded properly, but we need to do the benchmarking to understand that properly and bring that back into the room. And I know Kathy's asked me if I will include community dental in the focus on community services and social care, which we're going to bring back next time. So we'll do that. Thank you.
Thank you very much. We can continue the insight into this, and through our engagement session this morning, I know, Carol, we haven't got you on the list to contribute, but there is something about making sure we all as a board have an understanding of how the contracting and commissioning and the history of this is something that all systems across the country are learning about, understanding the history and the context. And I think it's really helpful what you've all shared with us today about the background, but we can from this do a briefing paper as well that can then complement what Karen will bring to us for the July board meeting. Okay. We've got Kate, Mel, and I just wanted to invite James and Bev at the end briefly on sort of quality of service. So Kate.
No, thank you. And for those that didn't introduce myself, I'm the Director of People for the ICB, so good to meet you. I'm going to keep this brief because I think it's been said, but I think the two things I really welcome from Ian and the paper, but all the conversation is, firstly, that real opportunity of partnership and integration, and I think this conversation is showing to me that opportunity to do collective thinking and planning. And secondly, absolutely, you'll not be surprised, I welcome the recommendation of a collective workforce plan and really happy to support that. I had the joy and I think pleasure yesterday of going to Leeds University and spending time at the dentistry school. Complete coincidence in timing. This has been planned for some time. So thank you to Dr. Allen and the team there, but lots and lots for me to take away. Really practical suggestions, but also some great opportunities for shared thinking. I mean, things that have been mentioned this morning and this afternoon, Chair, the outreach opportunities and really asking the right people about where they are. I saw 30 chairs, not beds, with lots of dental students and patients really active, and the opportunities to make that happen elsewhere in West Yorkshire was really noticeable. And then the second thing, of course, we got into was skill mix and skill set, and it's the point that's been raised already. But are we using the right skills sufficiently so that our dental therapists, dental hygienists and other members of the workforce can be utilised to their full extent, which then supports the wider workforce plan. So I came away with huge, sort of ideas and thoughts, but real, the real message for me was there, you are our partners, and I think that shared workforce plan is really welcome. So thank you all. Thank you.
Great. Okay, and we can start featuring that as you report into our partnership board, which will include our local authority colleagues as well. Okay. Want to invite Mel next, and just to help Rob and Jonathan, I want to invite to respond as well. Jonathan, we're being asked to spend money. Perhaps you'd like to comment on that. And Rob also on the lobbying point. That would be really helpful. So, Mel.
Chair, I was reflecting at the start of this meeting, a lot of people said the words excited about bringing this together in the ICB because of the breadth of services that we touch. And I wondered whether we could commit to a World Cafe that would bring social care colleagues, general practice colleagues, dental colleagues, dental community colleagues, secondary care colleagues together to help us plan and support and prioritise our resources that we're talking about. And in particular, there's some groups of our residents that I'm sure that we could all learn from each other that we're supporting, whether those residents with learning disabilities. And if I think about the journey general practices have been on, for example, in Wakefield, in 14-15, unfortunately, we were only reaching 38% of our registered population that had learning disabilities. And that's only been able to be increased to 83% because of the amount of work we've done with other wider services like social care colleagues and community services. And I'm wondering if we can learn from each other on that agenda.
Mel, that's really helpful. I'm going to invite all our place leads through their place committees, Carol, yourself and others, to do that. But I think there's also an opportunity through our partnership board. Now we're open to doing more development sessions together on priority issues. And to note for the minutes, I've sent this paper to all health and wellbeing board chairs, all council leaders in our patch. We know they're continually having issues and complaints from constituents as well. So we want to raise awareness with them. So that's really helpful. Just want to come to James and Bev on quality, because it was something we heard from the Health Watch session today. I don't know, James, do you want to start us off?
Yeah, no, thanks. So
we've talked a lot about access today, quite rightly so, but absolutely see quality as the driver here. We heard this morning in terms of the case that we heard, in terms of we heard them on the phone, and it was commented earlier about the harm that we're hearing. And whilst the focus was on the money and what we could be saving and what we're spending on it, actually the focus really should be on the harm that's happening there. So I think I kind of welcome the opportunity, I'm sure Bev will say, in terms of the opportunity we'll have in terms of understanding those issues and being able to kind of pick up on those issues there. And I think I just want to also just, I suppose, reflect back some of the earlier comments. I think Jane and Jane and Emma, I think, talked about the clinical leadership that's have been involved, and that's one of the it's important that we are engaging. You've seen the success with utilising the clinical leadership across our place there. So I think here's another opportunity where we'll do that. And I think also for the board to be aware that, again, Jane is part of the Clinical and Care Professional Forum within West Yorkshire, so there's input there. But I also think there's a challenge in terms of, because this happens in our communities. This is where it's happening. Is how do we ensure we get that clinical engagement across our dental workforce within our clinical and care professional forums that we have in our place there, and within those communities. So that there's discussions we're having this morning with Rob and others on our table is that actually when we talk about whether it's our community, our communities, actually around the table, we've got dental around the table in our communities there. So that those preventions, those other areas that we might be thinking of that you were talking about earlier, and there are opportunities with our dental workforce to be able to bring in those dietary discussions and prevention there. So I think there's lots of opportunity. Quality is one of those which needs to drive this, and it's about doing what we can do across the system, but also most importantly what we're doing within our communities with that quality information.
Great.
Beth, have I left you anything to say? Sorry.
Never, but I will anyway. So I think in terms of the quality aspect, we've also got to add to what James said, we've got the structures in place where, I mean, we talked about where it went wrong, like we saw this morning in the video, and then we've got the structures in place. So we've got clinical forum, we've got system quality group where we're currently revising the terms of reference, so we can look at who we need sat around that table. And obviously we've got quality committee where if there are things going wrong or when we get the right data, we've got oversight then as a board as to where we may need to focus some attention. So I think that and then obviously there's complaints as well coming through, and we know that majority of complaints around dentistry is about access. So and we've talked about that all day, but if I may, Chair, I just want to add a couple of things because you've given me the opportunity to do so. What I've heard today many times is preventable, and I think that we need to focus, and we've got also a £4.5 million worth of opportunity this year, and some of the things that we're talking about that are aspirational. So in the next 3 to 5 years, it's one of the questions that we did answer on our table was what could it look like in 5 years, and some of that were really exciting. But I think that the next year, with a £4.5 million opportunity, with some of the really wider things that we could look at, like Carol, you gave a brilliant example of some work with the voluntary sector, and there's a massive opportunity with health visiting and school nursing, and I think that I'm not hearing any dissent. I'm just hearing let's get on with it. So I think it's a fabulous opportunity.
That's brilliant. I just wanted to hear from our medical director and director of nursing. That's really helpful. Peter, do you want to come back on that?
Can I flag up, I'm really pleased to hear all the prevention focus. There are some examples in Scotland where they've done it really well. Every child who has a general anaesthetic, that cost per child is approximately £1,000, which doesn't even cost the cost for wider society, the cost for the family. But we're very lucky in West Yorkshire in that we have a very strong research base to underpin these activities. So it is not just ideas or thoughts that will work, but actually there's some really rigorous research which shows what does work in our local community with our local population feeding into those findings.
Great, that's really welcome, but we also welcome learning from other systems as well, and we've referenced previously how NHS Confederation are looking at systems that went a year earlier than others than us, for example, on adopting the commissioning and having that delegated. So I think those examples were really helpful, as well as taking on local research. So thank you, Bev. We need to finish up soon, but I really want to hear from Jonathan on the financial proposition, and then Rob as some sort of concluding points, particularly on the point around lobbying. Jonathan.
Thanks, Chair. So I guess part of my role on the board is to advise on financial decisions, and there's a number of different aspects to that. One is around ensuring and advising the board on delivery of the plan, as I talked about half an hour or so ago. Also to make sure we deliver value for money for the NHS and for our population, and also to make sure we prioritise our resources in the right sort of places across the system. It won't come as any surprise when Ian and colleagues started to think about reinvestment of this recurrent underspend on the dental contract that we had a conversation early on. And part of that is absolutely informed by the NHS England very clear policy that says that the money is either spent on dental services in West Yorkshire for the benefit of our patients, or it will go back to NHS England. So for that reason, this is money that we've been given to spend on our population. It's been ring-fenced for dental services, and as such I'm very supportive of it being deployed in the way that it's been articulated in the paper.
That's really helpful as we reach our conclusion. Rob, your reflections as our Chief Exec.
Yeah, so I think it's been, as others have said, Ian has produced a really good paper which has allowed us to have a really good conversation with the right people. Built on, I think, the good listening event that we had prior to coming into this room. I think we've got a saying in West Yorkshire, we should stop admiring the problem and start doing something about it. And I think this is the opportunity for us to do something about it. We should take from previous conversations with Integrated Care Partnership that this is a priority for us, you know, operationally, strategically, and in line with the strategy that we have. And their steer was, if you have to direct some more capacity at this, you should. And if you want to invest in it, you should. And as we've heard from Jonathan, we can, because we've been given money to spend, which if we don't spend, we'll have to give back. So it seems to me that we should accept all the recommendations, because I've not heard any dissent from those recommendations, and those would help do what Bev has described, I think, which is get on with it this year and do something this year. I thought there were 4 other things that we can do which are linked to that, which we must do as part of that work. So the first was always seeing, we need to bring dentistry into the team. So when we talk about the integrated teams, integrated community teams, we should include dental. You know, Karen's talked about that in terms of the community offer, and we think about some of the work we've done elsewhere. But that's a mindset shift as much as an operational shift. I think the next is, when it comes to the workforce, I can see Sarah's arrived, and we've got Mel here from Wakefield. We've got award-winning health and care academies in each of the places being developed, which are recruiting from local communities in the way that we talked earlier to come and work with us. And we should include dental in that work in ways which I don't think we have so far, which might be part of the workforce plan. I think the other things we can do, I really liked the conversation about inequalities. You know, why have someone with autism wait until 4 o'clock for the operation? We need to learn from the work we've done elsewhere. So the 8-week pathway into mid-Yorkshire for surgery for people with a learning disability, if we applied that to, you know, dental procedures in hospitals, what would we do? And let's try and do some of the same things. On the green agenda, I think one of the good things about turning up here is sometimes you get a job to do as well. And you don't need to be on the board. I think you need to be where the work's getting done. We do have a work programme on the green agenda and sustainability, which dental colleagues can join. And I think we should make sure you're part of that with Frank, who is an anaesthetist by background, but goes much broader than anaesthetics into single-use materials and so on. And I really like the points made by Peter about research. So James and the team are doing some work around how we're bringing our research into view. How does that get in front of us when we're making decisions and choices? We do have the Bourne in Bradford longitudinal research, which is also connected to Leeds, and there are things we can do there. So I think there's 4 or 5 things that we can do which have come out of the conversation. There are then 2 final things I'd want to reflect on, which aren't our decision, which we want to, I think lobby is the wrong word, I think we want to encourage others to pick up, and we can. So the first is we don't have any local authority partners around the table, unfortunately, at this point. But local authorities have to consult with the public on fluoridation. And if there's sufficient evidence that fluoridation will be beneficial, they then have to ask the UK Health Security Agency to work with Yorkshire Water, across the whole of Yorkshire Water, to fluoridate the water. I think it's a good thing for us to ask to be done and to consider being done, and for the Health and Care Partnership, the Integrated Care Partnership, to consider, alongside the Birmingham-Wolverhampton experience. I'm aware that it used to be the case that Calderdale and Kirklees had the same experience, but they decided to take the fluoride out of the water rather than put it into the other water, with the adverse effects that you'd expect as a result. So I think there is evidence that it works. The other thing that's not our choice, but we should continue to encourage people on and have the opportunity to, is around the contract. So with the Department for Health and Social Care, we have some work through the Policy Observatory about how can they change policy to help deliver improvements in their stated aims around improving the health of the population. And dentistry is one of the things we're working on them with. So we can take these points and this practice, I think, very carefully to policymakers and say, there's an answer here which, you know, you would like, we would like, actually works. So I think that's the way we might do that, Kathy. But I just wanted to thank all of the colleagues who put so much time, effort and energy into this, and for coming in today.
Thank you very much, Rob. So, board members around the table, we have a number of recommendations, including on supporting the approach overall outlined in the paper, flexible commissioning being extended, improved data and evidencing that we need, a workforce plan, and increasing commissioning capacity linked with using the £4.5 million for this financial year. Board members around the table, are you happy to support the recommendations? Great, thank you. I hoped you were going to say yes. What this means, which is what I found when we have these kind of topics, is now there's more work to be done, isn't there? And I feel this is a topic, particularly on, reflecting on Rob's points there, that we can take to our partnership board, which I think is on the 6th of June. We can take it again to the September and the December meeting to work with our local authority colleagues. And I think there's some more work in places, as well as with clinical networks as well, that we can do. We're a clinically led system, James. You've talked to us about this for well over 18 months, if not 2 years or so. So that is a key thing for us as well. And we've got various points where we can have oversight on plans, progress, and the quality of the service as well. And also going back to how we began this morning and talking to Healthwatch, we can go back to those local people who've shared their stories with us to say, we've made some decisions today to try and make progress. Okay. Thank you so much, colleagues, and thank you to those of you at the end of the table for joining us today and taking time out of your busy days. We really appreciate it. This is a conversation to continue, but we really welcome you coming today to help us make this decision. So, thank you. We'll take a break now, and thank you, Ian, again. Welcome back to the second part of our NHS West Yorkshire ICB board meeting. We've just had a really productive discussion on oral health and dentistry, and thank you again to all colleagues around the table for their contributions today in the preparation of that report. So we're now going to move on to items 7 and 8 around the Chair and Chief Exec's reports. As you know, my report as Chair of the board covers a number of things around strategy and governance, and wanted to particularly thank colleagues working on the annual governance review, which we're going to be hearing more about later, on ways of working, and to you all through the variety of forums and committees, particularly at place level, that you've been working on to try and learn from the last 12 months or so as a new statutory body to improve the next 12 months. I just wanted to highlight a couple of things in my report, but before I get into that, I know Rob and I and Bev, I don't know if I'd like to invite you just to talk about the work that has been going on during the industrial action, and I know that you, with colleagues, including Anthony sat next to you, have been thanking a number of staff who have been working across our system to make sure that we're running safe services, and thank you to you as an incident management team as well. But Bev, I don't know if you want to share some reflections as well. I know that it has been a challenging time for colleagues, but we've worked well together.
Yeah, thanks, Chair. So yeah, incredibly challenging. I think for many of us across the system, the last RCN action that was a couple of weeks ago now was the most challenging because, as members of the board will be aware, there were no derogations at that point, and we had to submit individual requests for staffing by ward. So there was an enormous amount of work undertaken by the providers that were impacted. So there were Bradford Royal Infirmary, Leeds Teaching Hospitals and Leeds Care Trust. But the system came together to look at opportunities for mutual aid and what we could do before, during and immediately following the industrial action. I think it worked as well as it could have done, but I just think to acknowledge the work that was undertaken across the system, in particular the organisations that were impacted. Thanks, Chair.
Very much. Very much appreciate it. And to you and Anthony and others on the exec team as well who've worked together. So key points just to raise in my report. One is that we had our first in-person community services provider collaborative, which came together. And what was fantastic to see, because I went along for the first part in person, was the variety of people coming together from the voluntary sector, GPs, acute community mental health services coming together to work through the best practice in integrated care. So I have invited Karen and colleagues from that developing provider collaborative to take our July Focus On session to look at integrated care, and Karen particularly will be bringing the results of that session to us. So thank you very much for that. We're continuing our work with West Yorkshire Combined Authority, and we shared earlier, Fatima is now in post in a shared role, and we also have Jen Connolly in her joint public health role, and we'll be hearing more from them both, particularly through our partnership board meetings going forward. Some other points to raise, as you know, it's board appraisal time, our first process that we're going through. I know we've been starting that this week, and thanks to everybody who's been working on this. And I particularly want to thank him in advance of my appraisal, Jane, as our Senior Independent Director, for working with me on navigating this first year, where we have been working with NHS England to define the guidance going forward. And my last piece of news is Harris is extending his contract with us on his next director placement with us in a non-exec director role, and I'm really grateful to him for staying with us till the end of the calendar year and his contributions. This is a mutually beneficial way of working, and I'm grateful to you for the time that you give us. So it's an overview from me. I don't know if anyone's got any questions, but as I said, I use this report particularly to evidence the governance work that's going on at the moment. No? Okay, thank you. We're going to record work on the annual report and accounts later, aren't we? And we've got our AAA from the Audit Committee that will reference that later. So thank you. I'm going to hand over to Rob now for item 8, which is the Chief Exec's report.
Thanks, Chair. So in the interest of time, just take the paper as read. And just to reinforce one point, so we are in a period of transition, I think. We've been a statutory body for coming up to a year, and we're in a period where the financial position the position on living with COVID, the operating model of NHS England, the operating model for this integrated care board within the integrated care system, all point to us having to respond in a different way, to become something different in a different system. So retain all of the things that we do, which is really good. So like the chair, I'd like to give my thanks to all the people involved in overseeing the industrial action, those who spent time on 2-hourly calls, 24 hours a day for the period in which they were conducted, those who did all the planning in advance, all of those staff who said sorry to someone because they had to let them down because of the impact of the action, all of the staff who felt that they had to take action because of the position they feel they're in. We need to make sure that as we move forward we create a sense, we've already heard about the financial and operational plan for this year, this period of transition towards something better and different, I think, is where we are at this point in time. And you can see that in the conversation just had about dentistry. The thing that we've heard from Health Watch is the biggest issue that they hear from the public constantly and have done for several years is something that we're going to sort out collectively. So just wanted to make that point really. We are in a period of transition. As we look at that, we need to retain our focus on improvement and delivering our mission of improving outcomes for local people in West Yorkshire. So apart from that, Chair, people have got the reports. Very happy to take any questions.
Great. Thank you very much. We've got Richard, then Fatima.
Before I answer that, it might be worth just hearing from Karen, who I know has been making some similar points through Social Enterprise UK.
Yeah, so as you've rightly said, any non-NHS body is not covered under Annex A for the non-consolidated payment for the uplift for last year. We've raised the issue through our national body, Social Enterprise UK, and they are making representations at the highest possible level to try and get that moved and shifted. I am writing to Rob and Kathy on behalf of Social Enterprises in our place. I feel very strongly about it. Our colleagues worked exactly the same as every other community service through COVID, through the winter, through supporting all of the pressures. So yeah, it's a challenge. We continue to lobby about it, and we'll make sure that all the other organisations such as hospices, general practice, etc. are included in that. I haven't seen a shift as yet. I don't know if anybody else has, but we continue to work really hard.
Jonathan, I don't know if you want to say something about the financial arrangements before I give a response.
Yeah, I mean, I think I concur with sort of Karen's assessment, really. It feels as though as a system, it's something we've lobbied about for a few years now, in terms of parity between the various parts of our system. Yet it's something that we're aware of, we're conscious about it, we continue to lobby. To an extent, we are reliant upon the funding that we get made available as a system to discharge our responsibilities. And I think we'll just continue to do so.
So we've got a very strong and clear line from NHS England that the resources that are being made available to us to fund NHS staff under NHS contracts on Agenda for Change at this point. At the same time, I think we've got a view about our people plan and how we ensure that people feel they belong, they're appropriately rewarded, etc. And it has been the case in the past that we have tried to ensure that people who are on different contracts, which may be down to their employer or to their sector to manage, that we try and do something which will aid their sense of belonging, recruitment, retention, etc. So I think we, unfortunately, Kate's had to step out of the room for a minute, so it'd be good to get a view from Kate as the Director of Workforce. But I think we should take this into consideration and understand the impact of not supporting other sectors on our people plan, recruitment, retention and resources. I think that's as far as we can go at this point, I'm afraid.
Okay, and we note the letter coming through representing a variety of sectors. So next question or comment is from Fatima, then we have AC, then John, and Kate's about to rejoin us.
Thanks, Kathy. Thanks, Rob. Really comprehensive report. There was some reflection from the Strategic Race Equality Network about the primary care improvement plan that came out, and some concerns from colleagues, particularly working in the pharmacy sector, about a shift in regards to demand and ensuring that we think through that in regards to implications of both capacity and resource. And I'm sure that James and Ruth are started and working on that, but they were keen for me to sort of amplify that to the board. The other thing was a reflection on the current operating model challenges, and a reflection that quite often the disproportionate impact in those changes impact people from the global majority. And it is with that in mind that they wanted to thank the board for recognising that and supporting a member of the Race Equality Network to be part of those conversations. I suppose what I want to add as the inclusivity champion is a recognition that that shouldn't be to the detriment of other staff networks as well. So I'm keen to pick up a conversation with Kate and colleagues about how we can exemplify and build on that model to ensure that all our staff networks feel heard and able to contribute to those conversations.
Thank you. And Kate, I know you've just rejoined the meeting, but we'll come back to you in a moment just on that point around Agenda for Change and staff who don't sit under that and the support of them in terms of pay going forward. Fatima, then we go to AC, John, and then Jane. So Kate, we'll come back to you in a moment.
Thanks, Kathy. Thanks, Rob. Again, comprehensive report there. I wanted to pick up on 2.8 about the NHS 75th birthday survey. It looks like a very exciting piece of work because it's going out countrywide to gather opinion and feedback from service users on what the features of NHS will look like. I've looked at this survey. I think it's partly, it will be interesting to see, would the data be shared with systems in terms of, so of course they'll do a top level analysis, and I know you're part of the steering group, so that's very helpful. Will we get a sense of what the representative view is from West Yorkshire?
Yeah, so just to clarify, it's not a survey. So what's been requested through the NHS Assembly, and Fatima's also a member of the NHS Assembly, is NHS England have asked for this piece of work to be done by the Assembly with a report that gives some advice around where's the NHS been, where is it today, what needs to change for the future. And in helping support the Assembly, a range of conversations have been asked to happen, and what people have seen is the conversation guide, which helps steer the conversation. So just to give you an example of the kind of things we're doing, board colleagues I think are aware that we've got a strategy group which is drawn from staff right across West Yorkshire, all levels, who've been helping develop our strategy. Their conversation this week is to have this conversation and feed back. Next week, Race Equality Networks and myself are going to have the same conversation, and there'll be a broader conversation with staff. And those conversations, we hope, are happening in all 42 ICBs, and we've asked all providers to have a similar conversation, and anyone else who wants to have one, really. The ask of the Assembly is we do try and consolidate that into some kind of position. So very happy to share that more broadly. And then it'll be for the Assembly to come up with its final report on what it thinks NHS England needs to hear. And I'm hoping that what we'll see is something which is refreshingly clear and honest about where we've been, where we are today, and what we might want to do in the future. And for those who've not been to the Assembly or seen it, it tends to be, because of the representation that we have there, a very full and frank arena for those sorts of conversations to occur. So very happy to share what we come up with here, see if that's helpful.
Yeah, absolutely. And I think because I've seen the questions through in terms of the questionnaire and the type of, it looks like something that would be interesting for us to consider. So it will be a joint response from the system that goes in rather than individual responses, because it looks like an open sort of a questionnaire format that has been set up.
We can put in as many responses as we like. I think to help the Assembly, there's been a request that can you try and consolidate if you can. But if we wanted to put separate returns in from the strategy group, the race equality networks, then perfectly okay for us to do that. I think the critical thing is to also recognise that people like the Patients Association are represented on their patient groups, Royal Colleges, they're having conversations too.
Perfect, that's helpful. Okay. And one suggestion, in terms of just thinking about the report in itself, now we are 1 year in. Will it be useful to have a top-level summary from yourself in terms of the 10 ambitions and how we're tracking that? So I know that, of course, we'll be tracking it at sort of various performance, but just your snapshot might be a useful thing to feature, just sort of a suggestion for consideration, because that will bring that to the top of our sort of purview all the time.
It's essential that we cover the 10 big ambitions and where we are on them on a much more regular basis than we have done to date. And Ian and colleagues, Ian and Anthony, can provide an update on where we're getting to in our plans for that. But we should always come back to that ASC, definitely.
Great. Thank you. John, then Jane.
Thank you, Chair. Just a brief comment on para 2.6, when it's about working to sign off the NHS financial plans. We focus on safety and quality. I guess I don't need to actually say this, but we also, in looking at any NHS plans, need to focus on the impact on inequalities, and I'm sure that would have been included, but just want to underline that point.
Thank you very much. And that was something referenced under urgent decision, and I'm sure we'll come on to that later on in the finance report. But John, thank you. Jane.
Thanks, Cathy. Yeah, I was interested in the annex to your report, Rob, in terms of the summary from NHS providers, I think, about the Hewitt report. I think you'd been part of that, the group that fed into that. And I was looking, I'll reference the page number in case anybody wants, but page 135 in the pack for today. There was a section about, ICB's relationship with providers and, comments and reflections on that. And obviously, we're 1 year on. We're doing our governance review, etc. But it kind of seems to describe something different, maybe from how we currently operate. And I'm just interested in, one, what's going to happen with the Hewitt report, and two, what are reflections on that part of the report, please?
So in the Hewitt report itself, I think is helpful in many regards in terms of the direction of travel and the reinforcement of the importance of inequalities, system working with partners, thinking about local context as well as national targets, and other developments like giving more freedom to high-performing systems. The response to the Hewitt review, so we were discussing this with our NHS Confederation colleagues yesterday, from the Department for Health and Social Care is to respond in due course. So there's been no formal response from the Department for Health and Social Care, and there's been a number of responses from others across government and others who may have an interest in the Hewitt review. So I think through the NHS Confederation, we're looking at how do we get a sense of what the recommendations will do and how they will be accepted or not. So the Chancellor has responded positively, and that's a good thing, I think, in terms of the review. But we wait to see what the overall government response is. There'll be other elements of government business which the review will speak to, such as the Health Select Committee's reports into integration and into the state of health and care, which may give it more teeth into the future. On the point around working with providers, I think that we are very clearly of the view, and this is reflected in our constitution, all our documents, that this organisation sits in an integrated care system, and the system is made up of local government, the third sector, the NHS and communities, and we're governed by an integrated care partnership board, and the providers work as part of that system to be successful. They're represented round the table today, governing our organisation as part of the arrangements. And as we look at the operating model for the future, we expect that more will be executed in terms of delivery through our provider collaboratives, whether that's in places or across West Yorkshire. So we've heard from Karen talking about benchmarking community services. Sarah can talk about SpecCom, especially commissioned services in mental health, learning disability and autism, or our learning disability challenge, or any number of things that provider collaborative is working on. Rob could talk about our elective recovery and cancer performance being driven by our Association of Acute Trusts. That's because providers are a part of the system as much as we are, and believe that too. That point needs reinforcing often, I think, in other parts of the country, and in some of the debates that I hear, which seem to be leading to people wanting to reinforce a purchaser-provider split rather than a collaborative effort where we have mutual accountability.
So, well, yes, I guess it's, do we think there's anything as yet in there that we need to reflect on as an organisation, or are we saying we think how we're doing things is right for the population and closely enough aligned to the framework and what the Hewitt reports say? Sorry, just to push a bit more.
So happy to ask Ian for a view. My personal view is that we've adopted a position of our work and our OD is in line with the Hewitt arrangements, but we're always happy to look further.
Yeah, I mean, I think the governance review that we're doing and the operating model work that we're doing is going to be important, and I think using that to test whether we're as effective as we can be against the, what we're learning from other systems, what we're learning from the Hewitt review will be important. I don't think, certainly when I read that document, I didn't think, crikey, we need to have a rethink here in terms of the way that we're structured and the way that we're doing things. I think there's still something about some of our arrangements bedding in. I think, as Rob has described, some systems seem to have a much more arm's length relationship with some partners rather than an integrated way of working, which is something that we're working really hard on to continue, because that's seen as a strength over the last 6 or 7 years. So I think it's probably more about course correction through the processes that we've got, such as the governance review, and ensuring that we're open to learning from other systems and evidence from the Hewitt review.
Great. AC, did you want to come back on Hewitt review?
Yes, please. Thank you. And just sort of not necessarily pushing on that one, but there's an observation in that review in terms of, generally speaking, provider collaborative seems underdeveloped or evolving. That's an observation as per the report. What is that? Is that something that is your view in our system? Is that something? Are we doing something specific in order to improve that integration within the overall?
I mean, it'd be worth just asking Sarah, Rob, Karen for a perspective, I think, and then I might give a perspective about place-based provider collaboratives.
So Sarah, on behalf of Mental Health, Learning Disability and Autism Collaborative.
So trying to say this in a way which is fair and balanced, but I think we've probably got one of the most mature in the country in terms of our collaborative on a number of levels. The comprehensive focus of our programme board, which has wide engagement, representation from the VCS sector. In fact, it's VCS colleagues at the SROs for our Community Mental Health Transformation Programme for West Yorkshire, and I think that brings a huge diversity. We're bottom up, so we're driven by understanding the needs of our service users on different population footprints. What do we do well at place, and what can we do better at place by sharing, and then what can we do better together, because we look at transformation, alignment of standards, or service reconfiguration. And then the work that we've done on devolution of specialised commissioning, again, not been easy, not been without significant risk or an appetite to take on risk in order to do things differently, but we're seeing that pay dividends. We met last week face-to-face as executive teams from our the formal aspect of the NHS provider organisations to meet with Tim to go through where we're at with the review of the operating model and what that means for us in our sector. And to be fair, our view at the end of that was the work that's being proposed actually won't bring significant changes or issues for us in the way that we work as a provider collaborative. And then secondly, I think we had a really mature discussion on capital requirements for our sector and what we can do as a group of partners in support of one another. We're not in competition with one another, and we're not in competition with partners in the integrated care system, but we need a clear narrative around what does gold standard look like for our service users within our sector, and where can we leverage our position as an ICS to lobby and influence elsewhere. So that's very much the way that we work together, just as a flavour. And I know we're going to have a focus session in September on the work that we're doing in mental health, which will give you an insight of where we've got lots of successes, but where we're really honest around the challenges that we cannot solve by ourselves.
Great, thank you. Karen, if we go to you on the Developing Community Provider Collaborative, and then Rob will come to you.
Yeah, and I think you've probably potted it there, Kathy. It's developing. I think one of the interesting things nationally is there are very few community services collaboratives, and one of the reasons for that is because a lot of the feedback is, well, we do this in places. What we've managed to get to is that actually there are things that we can do together, so we can look at our workforce issues, our benchmarking and data issues, and the digital agenda, which will really shift the dialogue, but also that we wanted a voice in the room, that we wanted to be able to come into the room and talk about supporting people where they live, and that shift that's going to enable us to manage all of health and care in the future. I think we have demonstrated we can do things together, so the fact that we won together as a collaborative the school immunisations contract from NHS, I think that proves that we can do this together, and that was not without its challenges and difficulties. And the fact that we did run a time-out, which a number of the people were here for, that included more than just community services. We're not an island. We need to deliver with our voluntary sector, which Sarah talked about, mental health, social care. So we had a lot of people in the room, and interestingly, we had Crystal Ullman from the Queen's Nursing Institute and also Sam Sheringham come along, who is the nursing lead for community services at NHS, and they were incredibly supportive of the collaborative that we've built. So although it's developing, I think we've got a really great foundation, and we definitely have a voice in the room supported by colleagues like Rob and the team. So yeah, we're on the journey.
Yeah, thank you. And Rob, I know you were at that community collaborative, but would you talk on behalf of West Yorkshire Association of Acute Trusts?
Yeah, and because Karen was giving me a compliment, I've got to agree with Karen, haven't I? But I absolutely agree, and I think I read that statement there about the kind of provider collaborative being underdeveloped, and I don't think that is us. I think we're quite far on. I think, thinking just from a Wyatt perspective, I think even just 5 years ago when PBR was very much, the thing, and we were competing with each other, and there was a level of competition across Wyatt, I think the relationships now are excellent. I don't think that it is based on competition. It's very much around collaboration. And I think the bit we've done really well, I think, is collaborated kind of intelligently. So we haven't just thrown everything into the mix and said we've got to do everything together. We've worked together on things like elective recovery, non-surgical oncology, that have been the right things because they've been the things that have been needed the most focus and the biggest gain from collaborating together. So really optimistic about what we do together. I think we're continuing to look at where there is an opportunity to work at scale, particularly those fragile services. And I think the engagement across kind of multidisciplines, kind of finance, operations, nursing, we've got it across the board, right down into the kind of teams and services. So absolutely think we're ahead on this, and we need to keep building on it.
That's great, thank you. And I'm just wondering, in terms of improving our board knowledge, it was something that Carol raised earlier in our engagement session, making sure we've all got the same foundation as when, Karen, you bring in July the focus on session on integrated community services. Maybe you could include some background on how the collaboratives come together. Sarah, when you come to talk to us in September on mental health services again, something on the collaborative, which is a few years ahead. There's also an NHS providers write-up on it nationally as a case study. And then I think as we're looking, I think we're asking you, Anthony, to bring something on learning from winter. Maybe we can then bring Wyatt's examples of ways of working as well, so we can keep bringing back reminders of how these collaboratives are working well together, and any national case studies, because there is national interest in our ways of working. Rob?
So I think that's a really good reflection of the work in the collaboratives across West Yorkshire, and there's some really great learning on things like the transfer of specialised commissioning responsibilities to the providers in West Yorkshire on forensics and specialist mental health and learning disability services is a great model for thinking about wider specialised commissioning later for acute services. The area where I think there's a lot of work to do is in provider collaboratives in places. And we've talked about this as a board before, and I think we talked about with colleagues, what is the vehicle for integration in place? It'll be different in different places, given the provider configurations, but increasingly there will be really good collaboration. And I know that in Wakefield, for example, they've got a really good planned care collaborative in place and a good mental health alliance in place. And in other places, they've got different arrangements. But if you look at the operating model, it's likely, isn't it, that we will be asking providers in places to do more collectively and leaving them to it. And for us as a board, just setting the outcomes that we want to see. And that will reduce the duplication of effort, that will ease decision making and increase agility. But we need a vehicle for that. So I think the board should, it's a really good question, and the board should think about, as we're going through the process of what the operating model is going to look like and our OD plan, what do those arrangements in each of the places look like?
Thank you very much. And I know through our development session that we had in April, where we were looking at financial scenarios and ways of working together, there was something about how we can support places, exchange learning and practice, and support innovation that's coming through, which is either a regular 6-monthly or quarterly engagement across places as well. Mel, did you want to come back? And then I just want to move us on to the next item.
Yeah, I know many places are looking at reviewing their place collaboratives. We've certainly recently done a review, but there's also a national tool out now, which is a maturity matrix for provider collaboratives, which came out on the 18th of April. So that might be a tool that we want to consider and look at.
That's great. And also we have our place framework that was set up 18 months ago, which Audit Yorkshire worked on, which gave the ICB, we as the board, the assurance to delegate to places as well. So we have that. It's homemade here in West Yorkshire that we can use alongside other tools that are coming through as well. Okay, so it's given us something to take forward. Thank you, colleagues, for contributions on that. But we note we're still awaiting Government and NHS England responses to the Hewitt review, but we do know in working with NHS England colleagues, they're encouraging us on our response to that. Rob?
I just wanted us not to lose the points that were made about pharmacy. And, you know, the fact that general practice colleagues will often say they're the biggest touch point in the NHS, but actually I think it might be community pharmacy. In terms of the number of items dispensed is greater than the number of contacts with general practice even, which shows the value of good pharmacy and the value of those relationships where you have a good relationship with a chemist locally in your community. But we also know there's significant pressure on pharmaceutical services. We do pharmaceutical needs assessments, and our places are engaged in those. So I think we might want, at some point, I think either through the Hewitt board or through some other mechanism, to have more of a strategic or tactical conversation about pharmacy.
Could be a focus on topic for the future. Ian?
Yeah, just really briefly to add, we're seeing the GP recovery plan as part of the fuller vision and part of the whole around integrated services and communities and in places, and we're using the fuller board as the vehicle for that, which has pharmacy representation. So we're trying to join it up however we can.
That's great. And we do want to invite the fuller delivery board to report back to us following our focus on session on particularly GP services back in November, what you heard then, what we discussed then, what's the progress, what's the difference made. And I know for any residents we spoke to that day who had mixed experiences of GP services, I'm sure they'll be very keen to hear about the progress made as well. So Karen and Ian, we'd welcome that coming back. Advise us when that would be a good time. Kate, we wanted to invite you to come back on members of staff that don't fall under Agenda for Change, and Karen said that she'll be sending a letter to us shortly. And Karen.
So can I just say that the colleagues are on Agenda for Change.
Some
of them tupied into organisations on Agenda for Change. They're just not in statutory bodies as per Appendix A. Sorry to correct.
No, that's absolutely fine. Thank you for the factual correction.
Sorry, I'd actually put my hand up just to add to the pharmacy piece, but I'll do both.
For it.
The pharmacy bit, just to say, I've made reference earlier on to the Primary Care Workforce Summit that took place about 3 or 4 weeks ago, and some of the sessions that colleagues could attend was all about the benefits and strength of community pharmacy and its contribution. And I have to say, they were really well attended, and particularly by GPs in the 120 audience. And I think it's something around that workforce steering group that reports to the full board for primary care. I think that whole strength of the pharmacy workforce was really recognised, but actually, as ever, more can be done. So I just wanted to reference it was something that was of a particular note I felt at that event. Going back to the point that Karen's raised, and apologies, I recognise I missed the conversation, and I'm sure Jonathan's probably covered some of this already, but our position is, yes, we continue to raise these points nationally, and I think also locally, just to really understand some of the real implications of this. I mean, I personally have a meeting with the Community Services Collaborative tomorrow, and I'm sure this is one of the areas that may well come up in that conversation in terms of the workforce implications. But yeah, we continue to raise this.
Okay, and we can take an action to keep the board informed on that if there are developments before the July board meeting, and we'll bring that back then. Okay, colleagues, thank you very much, and thank you, Rob, for your report and the responses as well. We appreciate you being involved with national initiatives and forums such as for the 75th birthday, as well as the Hewitt Review as well. Okay, we're going to move on now to item 9A, which is the Integrated Performance Report, and our aim really in this is trying to bring together a number of things around risk management, financial planning, and our integrated performance report. And just to note, we continue to have a board task and finish group looking at the integrated performance report, and the next meeting is tomorrow. So colleagues around the table, thank you for being your robust contributions and critical friendliness in those sessions to try and develop this so it works for us in West Yorkshire. So Anthony, I think, if there are anything key highlights you want to share with us from the report?
Yes, thanks, Chair. And I suppose just to start by saying the task and finish group you mentioned, which meets tomorrow, is addressing the point that was made earlier about how we report on the 10 ambitions, as well as the more routine NHS-focused performance data. So that will become a feature of what's reported to the board on a more routine basis through that work. But pending that, the report in the pack is the kind of standard format of updates on publicly available NHS data on a range of metrics largely derived from the NHS oversight framework. So you've got the full dashboard and quite a detailed commentary in the cover paper. I thought it was perhaps worth just drawing out 3 or 4 issues just to bring up to date how we're doing as a system on a couple of a few key issues. So I was going to start with urgent and emergency care and performance against the A&E standard, and this is featured on page 152 of the meeting pack. I just wanted to note the fact that Airedale Trust is and has been for some time an outlier on performance against the A&E standard. It's some way below the sort of level of performance of the other trusts, and just to note there's a number of actions taking place led by the trust, but with partners to address that. So that includes targeted work with the Emergency Care Intensive Support Team, which is a national improvement resource. Also some peer review work with a neighbouring trust or a trust in the neighbouring ICB, and a demand and capacity review by NHS England. So we're helping the trust to draw together all of the sort of elements of work there that so we're hoping will have a sustained impact on A&E performance, which has been driven by a number of issues, particularly around staffing problems, high demand through the winter, but also the estates issues associated with the fabric of Airedale Hospital, which I think the board is well aware of. So just to note that has been an outlier, but is subject to some detailed work for improvement now. Wanted to mention cancer performance, and this starts on page 155 of the meeting pack. And we noted in the last meeting of the Finance, Investment and Performance Committee that performance in January against the cancer standard has been very challenged. So I just wanted to note that the data for February, which is in this pack, demonstrates there is improvement there, and we're confident that will continue to improve. West Yorkshire Cancer Alliance actually compares very well with other parts of the country in terms of performance against the key standards. So you'll see on the faster diagnosis standard on page 155 that we're exceeding the 75% standard there, and again, as I say, comparing very well nationally. The 62-day standard, which is on 157 of the pack, is below the national standard, as is the rest of the country. But again, we compare well, and the number of people who are waiting longer than 62 days for treatment, the backlog of patients is actually the smallest as a proportion of the number of people waiting over 62 days as a proportion of the total number of people waiting is the smallest in the country. So just to reflect the continuing improvement we're seeing there, and relatively good performance of West Yorkshire and Harrogate Cancer Alliance. Just two more items to note. One on elective recovery. I think everyone will be aware there's been a significant focus on tackling long waiters, and 159 in the pack shows the progress we're making for the key long waiter cohorts, including people waiting over 78 weeks for planned care and over 65 and over 52 weeks. There was a key milestone for the end of March to eliminate 78-week waiters. We actually had a plan in West Yorkshire to get down to 85, and that they were predominantly spinal patients who have very complex treatment requirements and can only be treated by a very small number of providers, often by a tiny number of clinicians. So the complexity of those cases meant we were aiming to get to 85 rather than 0. In the event we got close to that, the performance was affected by industrial action, as we've talked about earlier, and difficult winter. But the end-of-year performance was around 115. And work is now going on with Leeds Teaching Hospitals, which is where those long waiters are mainly, to aim to eliminate waits of 78 weeks by July. And Leeds Teaching Hospitals is now part of a national support programme which will aid that further work and bring in capacity from across the country where possible to help with that. Finally, on primary care, just wanted to note page 179 of the pack, the slides on primary care, that we're seeing GP appointment levels consistently above the standard of 400 per day per 100,000 population, and that's a continuing improving position. And equally on the subsequent page, you'll see that the proportion of face-to-face appointments continues to improve. So that's responding to people's choices and needs for face-to-face appointments where they are appropriate. So just wanted to draw those points out as bringing the information in the report up to date and demonstrating where we're making progress or dealing with areas of concern. So I'll pause there, Chair.
Thank you very much. I just wanted to invite Jonathan on the financial side and Laura anything on the risk register. This is my suggestion from the last meeting in trying to take this pack and a selection of information together so that you can then we can talk in the round about system performance and risk. So Jonathan, is there anything you want to add in terms of finance?
Thanks, Chair. Yes, I would. Obviously, this report contains a position for the full year 22-23, so it's a useful time just to take stock of the year now that that's passed. And there are 5 areas that I just want to talk through, 4 of which are summarised in the report. The first relates to our financial position for 22-23 across the 11 NHS statutory organisations. So we had a break-even plan as a system. And we finished the year with all 11 organisations being either at plan or slightly better than plan. So we actually finished the year with a £0.7 million surplus, with 4 organisations just performing slightly better than plan, which in the scale of a £5 billion budget is fairly close to the mark, really. So that's a really positive thing. That position is still subject to audit across those 11 organisations, but that's the results and that's the assumptions we're working to at the moment. So that's one of our strategic oversight metrics that NHS England will judge us against. The second is around the level of efficiencies that we've delivered as a system, and collectively across, again, the 11 statutory organisations, we've delivered £315 million, which is £22 million better than plan. The third area that we've looked at in the report is around the delivery of the mental health investment standard. And again, pleased to report to the board that all 5 places have met or exceeded the required standard in terms of investing disproportionately and higher in mental health services than in the other services across West Yorkshire. As we've previously discussed, we haven't complied or lived within NHS England's target in terms of capping the amount of money spent on agency staffing in the year. So we overshot that target by £22 million. So we spent 121 million pounds against a target of 99. And we had a good and robust conversation, I think, at the last board meeting around the factors that would cause that, primarily related to the need to ensure that staffing levels and safety are maintained in our wards and in our teams. The other indicator which isn't included in the report but which is really important is around our operational capital. So across the 10 providers we had £162 million to spend last year. If we overspend, that gets reduced in terms of the following year's allocation, and if we underspend, that's basically lost to the system. An awful lot of work has gone in to ensure that we maximise that 162 million, and we end up underspending by £100,000, which again I think is testament to the way organisations have worked and collaborated on that. So overall, a really positive position to report to the board, notwithstanding the challenges that I've described in terms of 23-24. So I probably just would want to sort of thank colleagues across the system, the places, the organisations, so the boards, the finance committees, the execs, the clinicians and managers that have managed to balance out, I think, a really tough year across money, workforce, performance and quality for all the reasons we've talked about before.
Thank you, Jonathan. That's really helpful. And Laura, just an oversight on the risk register.
Sorry, sharing a microphone. So yeah, members of the board will be familiar now with the format of the corporate risk register report. You've got details in there of all of the corporate risks. You also have the 15 plus place risks. I have set those out differently this time following feedback at the last meeting, and it hopefully gives you a better idea of the differing risk profile across the places. And you also have those identified common risks that are across 2 or more places. A couple of points I'd like to just draw your attention to, if I can, and suggestion around some areas that you might want to focus on in the discussion. We do have 6 risks that are now deemed critical, so they're scoring 20 or above, and I'd encourage the board to be reflecting on those risks. Do you feel adequately cited on them? Are you assured around the steps that we're taking to manage those risks? We also have a large number of risks that are remaining static, by which I mean that their score has remained unchanged over a number of cycles. It can be indicative of insufficient controls or assurance, and again would encourage the board just to reflect on those that are highlighted within the report, and whether you would want to seek further assurance on those. You also have a summary of the discussions that took place at both the Quality Committee and the Finance, Investment and Performance Committee. You can see there were some quite detailed discussions around different risk areas at those committees, and that's set out at paragraph 6.2. Probably the final point I would make is that obviously the report does contain detail around the processes we follow, but I want to encourage the board to focus on the detail of the risks themselves rather than the process, and to perhaps use some of the cross-references that we have across the agenda report. So you'll see that every agenda item front sheet highlights links to different risks, so hopefully it helps you to be able to use it as a tool throughout all the different items. Thank you.
Thank you very much. And as a new board and continuing to learn, I'd welcome board feedback in and outside of this meeting on how by grouping that together it's been helpful. Do we need to do some more work on thematic areas or analysis? Laura and I talked about this yesterday in preparing for the board, but actually I'd welcome any specific comments or questions on the reports that you have, and then we can capture feedback at a later date. So I don't know who would like to go. Mel, then Harris, then Jane.
Thank you, Chair. Anthony's raised in 2.2 the change for Mid-Yorkshire Teaching Hospital to move from the 4-hour standard, the national pilot, to reaching the 4-hour standard. And I just wanted to give assurance to the board that they were above trajectory at 77.3% at the end of April. So I just wanted to highlight the progress the Trust have made on that.
Thank you, that's helpful. Harris.
First of all, Anthony, really appreciate the more notes about the slides and the explanations. It makes it far easier to read. I've just got a point on the infection rates. If you're a member of the public looking at the infection rates in West Yorkshire, few trusts are in the red and a few seem to be on the upward trend. So I think it's important that we discuss why there's a lot of variation of infection rates across the system, and how, as the Integrated Care Board, we can help reduce the variation and have more oversight. My second point is on the stagnant risks. I looked at the September board paper, and quite a few of them have remained the same. So could we zoom into maybe the executive that is responsible for that risk commenting why those mitigations which are in place haven't worked, and what we can do collectively as the Integrated Care Board to help reduce this?
Thank you, Harris. If we take the first one on infection prevention, I had a similar interesting query as well on variation. It's something we're interested in as a board, isn't it, when there's variation across providers and places. We've talked about this in terms of financial planning as well. I don't know whether Bev and James, you want to respond on that one first of all, on the variation, and whether what the Quality Committee has looked at or could look at in future, as well as places. Bev?
Thanks, Chair. So in terms of the difference at place, if you look at where they're at higher incidence, it's the larger organisations which have a complexity of patients. They've got longer length of stay in the main. I'm generalising. But that's where they undertake, kind of complex procedures which are at higher risk, patients are at higher risk, and also regional, Leeds to regional centre, we get, major trauma to Leeds, etc. So there's lots and lots of different patient factors that contribute to an increased infection risk. In terms of your question that you posed around what we're doing about it as a system and how we're cited on it, there's some work around the more up-to-date data, and also we had every other week we met as a group of Director of Infection Prevention to look at, in the main it was around COVID, incidents, mutual aid, etc. We've now decided that we're going to step that down, and we're going to have a West Yorkshire Infection Prevention Committee. So we can look at all things infection prevention, we can look at differences in organisations, we're going to invite NHS, although they've got very limited capacity in terms of sharing learning from wider NHS, but also so that we've got up-to-date figures, we've got sharing of learning across West Yorkshire, we can also bring things from outside. Does that answer your question?
And Bev, perhaps while there are colleagues around the table from different sectors and places, what would you be inviting them to do as well? You've talked about what you will be doing ICB level. Is there anything that you want to ask colleagues around the system to be doing?
No, because I think they're involved. So we've got organisational DIPSs, so from every, Director of Infection Prevention from each organisation. And there's also, in the new revised terms of reference, we will look at if there's anyone else that we need from place, but they are really well represented. It's been a really well-established group that, as I said, was set up just before COVID. Oh, no, just after COVID.
Just after COVID. We've learnt so much, haven't we? Okay, Rachel, do you want to come back, and then we'll pick up on the stagnant risks in a minute, and then Majid.
Yeah, thank you, Chair. I'm Rachel Spencer-Henshaw, Director of Public Health for Kirklees, representing Public Health Directors here. I just wanted to follow up with what Bev was saying. So each local place has a health protection board that reports into their health and wellbeing board in most cases, and that has NHS England representation as well as the different trusts within the system. And there's a huge amount of effort goes into looking at any case, particularly around things like MSSA or MRSA, and looking at everything that we can do and learn. And we look at that consistently in terms of where we can share best practice with other areas. So there is a lot that goes on. I think from what you're saying, though, it's about how we articulate that as West Yorkshire level and be able to learn that a little bit more collectively, which I think would be most welcome, because I think most systems locally are really quite, equipped in terms of dealing with it, but it's whether or not we can benefit as a greater West Yorkshire system. So I'd really support that.
Thank you. Just on the static risk that we particularly have, so a system risk being around Airedale's RAC issues in terms of their capital needs. I know that we're going to talk about that in the private section of our board meeting, and for anyone observing the meeting or watching online, sometimes there are certain items that we'll take into a private discussion, particularly if it relates to a specific provider or patient or issue, but we will make sure that the information and minutes are available. The other one is around the sustainability of the voluntary community and social enterprise sector. So I hope, Harris, from the focus on session we had at our last meeting, we can start seeing progress on that. But there are systemic issues, I think, that we need to progress, which is probably a similar yet different in dentistry and oral health that we talked about earlier today. But please keep asking that question. Rob, do you want to come back on that? And then we'll come to Jane, then Carol, then Maggie.
Just, I think we're all aware of the issues to do with reinforced autoclaved aerated concrete at Airedale, and the actually the other issues with the concrete infrastructure, which aren't to do with that type of concrete, but just the structure itself. And I think we're all seized of the importance of getting a resolution to that. The route to that is through a decision which isn't ours. So we keep doing the things that we're expected to. And Cathy and I have raised this with the Secretary of State, who is very aware of the issues. And I know that there's a commitment from the department and from NHS England to get to a solution. In the meantime, I think it's important for us all to recognise that there are risk summits around the hospital and its services through Bradford District and Craven, and that those are regular to make sure that services are safe and that any mitigations around safety are taken. And as a consequence of that, we know that the EPRR teams are looking at if we had to, move patients out of there quickly, or if we had to do something different. That's the case. We've seen the fact that there's a variance in the ability of Airedale to deliver a balanced position, which is driven largely by additional costs because of RAC issues. I think one of the things that we would want to make sure is that when resources do become available, because I do believe they will, we already do have resources being given to us to shore up the building, for example. If we are given substantial resources to replace facilities in Airedale, we must make the route to spending that as quick and as simple as possible. And I think there's some prep work for us to do around Airedale and Bradford District and Craven to answer questions about clinical adjacencies and the way that the system works together to get the best possible outcome for that investment. So I know that we will be asked as an ICB, do we support any developments in Airedale? And we'll want to make sure we can answer that question in a straightforward way. So I know that Mel, Faluke, Nancy and colleagues are looking at some of those issues as we make progress in this space.
Thank you, Rob. That's really, really helpful to the background. I want to come to some other board colleagues now. Jane next, then Carol, then Majid.
Yeah, thanks, Cathy. So yeah, I'm on the risk report as well, and I guess as a learning organisation, just thinking about how we may be able to do more with it in order to help us have the right conversations. And I think picking up on the point about static risks, when you look at the risk map on a page, then obviously there are a lot there that are marked as static, and there's quite a few in a nice grid that shows that a lot of them have been static for several cycles. So I wonder if, but I think we also recognise that there are some where there is only so much that we can do ourselves, and then it does require other bodies where we don't have control. But that's not the case for all. And I guess if we were able to show, I think at the moment we kind of go from gross score, or it feels like gross risk score, to target, and there's nothing that kind of says the mitigations that we're taking actually improves it from a gross risk to a net risk. And then we could have a comment that says, in which of these cases is it that we are now subject to others, versus actually we now need to think if there's more that we can do. And I think that would then help sort of us focus where our time is on the ones that we can and should be doing more about. And I think that might help focus our attention through it, because at the moment it just looks quite stark, and that story is not being told. So I'd be keen to see that. I had one other comment in terms of I do really like the common the report that shows where there are common risks coming through from the different place committees, and I've talked previously around the idea of having some a thematic focus for certain areas that would help us sort of make sure we're having discussions around it rather than just looking at the numbers. So I was looking on page, what was it, 215 as an example under a common risk re-emergency department's demand, where 3 out of 5 of our places are, red or black in that scoring. So, as an example, taking that and bringing something back to the board or via quality committee that comments and reflects on that and what we're doing as a sort of area of, high level of risk across most places, I think might be an example to use, and then we could use it and apply it in other ways as we continue to enhance how we look at the risk stuff at the board level. Thanks.
Thank you very much, Shane, and your views as a non-exec and audit chair is really welcomed, and I think there's something we could take away to develop for the July and the September meeting, how we bring the information on system performance and risk management together, your point about having more information on mitigation, as well as that analysis and themes coming through, and whether that links with a focus on or not, it's just making sure that we're informed and have the oversight as the board. Rob?
So I think it's exactly right, and I think there's an opportunity for us to then make sure we've got the right people in the room to have the conversation. So I think that risk that you've identified, Jane's a really good one around delays in the ED potentially causing harm. We do have an urgent emergency care programme, and we've been looking at how does the programme and the people who contribute to that, whether it's the work we're doing on discharge or whether it's work we're doing on ambulances, etc., how do they come together to make sure we're focused on the root causes of the issues? So it seems to me that you could take that risk, we could get the urgent emergency care folk along, we could say, okay, let's get to the point of are we doing everything possible here?
Thank you very much, and this is very much, being a year in, we can then work out what's helpful to us, and I think connecting in the programme boards, we talked earlier about our provider collaboratives as well, how we bring them in and share the work that they're doing, as well as giving them the opportunity to engage with the board. Thank you, Rob, that's really helpful. So we're going to go next to Carol, then Majid.
Thank you. If it's okay, I wanted to go back to the performance reports. I know we're jumping about a little bit. I just wanted to make a couple of comments on the primary care, particularly the GP appointment slides. I think it's 179. And apologies, I am a member of the task and finish group that meets tomorrow, but I can't attend, so I might have saved my comments if it was going to be there. However, I think there is something for us as a board in terms of how we read some of this information. So the slide that shows GP appointments per 1,000 population, there's a standard there of 400. I'm not entirely sure where that's come from. Maybe I should probably know. But it looks like the higher you get after 400, the greener you become. And I think we need to be careful not to be too complacent with that, because while it demonstrates high levels of productivity, unless there's been significant increase in the capacity in those practices and places with that high level of productivity, it raises other questions about the impact on staff, on patient safety, all of those other things. And it's you would want, I think, in that, what you'd want to see is a ceiling on it, as well as a standard that we want people to be above. So there's maybe just something to be thinking about when we look at some of these other potential unintended consequences from things that look in the first instance to be performing well or demonstrating high levels of productivity, and it's one for us to think as we develop the dashboard a little bit, I think.
Thank you, Carol. That's really, really helpful. And Richard, I don't know, you're very welcome to come in a moment just to reflect on that, how we're reporting on primary care data and information. So thank you, Carol. That's something Ian and Anthony to note for our task and finish group tomorrow. Thanks, Carol. Majid, to you, and then Richard, if you want to come back in, just let me know.
Thank you very much. A couple of things. So the performance report commentary, really, really helpful. I think it really sort of teases out those sort of key issues that we need to look at. Couple of things. One around diagnostics. I lost the page now, but it says we sort of, in terms of delays with diagnostics, what is the issue? Is it a kit problem, people problem? Obviously, late diagnostic is going to cause us further issues down the road. The other thing was around longer stays for people with a learning disability under 6.3. I think a little bit more of an explanation as to what we're doing about it, or what could be done about it and stuff. Some of the most vulnerable people in society. So that was on the performance report. Then the second thing was on the risk register. So 2688, I think it was, around program funding. I've lost the page. Yeah, long-term condition 2268. So we've lost the funding, or it's been reduced significantly. I think just in the language, we should sort of acknowledge that this is going to have an adverse impact on our strategic aims around inequalities and variations, etc. That there's a risk to that, so we just need to reference that. And also, we wrote that we're going to send a letter to NHS England, etc. Okay, that's brilliant. But then what? We've still got this issue, and I know there's some local sort of discussions going on with program managers and stuff, but I think because these are potentially serious consequences if this work stops or reduces, more about what we're going to do about it.
I had that query as well on long-term conditions and support and funding. James, would you come back? And other colleagues, if you've got a response, please let me know. Richard.
Yep, no, thanks, Chair. So I can, in terms of long-term conditions funding, so there are two things. You'll note there are also the comments in terms of the FIPC comments as well, in terms of the risk as it is there. It was highlighted at the risk 16 because of that significant reduction there. And whilst recognising the FIPC comments in terms of as a percentage of the budget, it's not significant. I think also recognise what the comments from FIPC in terms of that impact and that impact in place. So I think it's in terms of the teams with long-term conditions, you're right in terms of how does that therefore reflect in terms of our ambitions and the impacts was potentially with inequalities there. I think it's those discussions are happening within our places. I think everyone is recognise that there will be specific impacts there. The letter was sent. I've had further discussions with region in terms of that. There is no extra funding. We weren't expecting that, but understanding this is about prevention. This is about personalisation. It's about making sure we don't defocus on that. But it's also about how we work smarter, both in terms of in places and across the system, so that we learn what works well across our places. But fundamentally, it is about how we prioritise as well. And those are some of the decisions that we will take within our places and our communities, recognising long-term conditions. That's where that happens. But I think at system level, it's how we support some of those decisions as well. So there are lots of discussions happening about it. There's things that are taking place, but there aren't any easy responses in terms of the solutions. But absolutely, it's core to those discussions.
Okay. I think this is what I call a watching brief, isn't it? And I think we can weave it into our focus on community services next time, as well as developing reporting in here as well. Rob, did you want to come back on that? And then I'm going to come over to Richard from a primary care view.
It was just an acute perspective view on the diagnostic question you asked, Majid. So I think it is an improving position. I think Bradford and Airedale, the main focus there. I think Bradford, particularly around endoscopy, has been a pressure in recent times. But we have a endoscopy network, and we're doing lots of work through there around kind of future planning. I think that just the point just to draw out is we've just looked at cancer being a really good position actually for West Yorkshire, and within that diagnostic standard there's a lot of prioritisation that goes on. So you can see we're performing really well overall, picking out those patients at highest risk, but notwithstanding there's work to do to get back to 6 weeks, which lots of activity behind that. But just to provide that reassurance around that triage and to make sure we're getting to those patients who are most in need clinically.
Okay, thank you. Richard, do you want to come back from a primary care perspective?
Yes, no, thank you for inviting me to do so. I mean, the indicators that we use within this dashboard aren't particularly helpful in terms of informing general practice quality. We could actually make the case that we should be doing less appointments rather than more. They should be longer. We're not measuring any of that, so we're not measuring the quality of care. We will, later in the summer, get the output from the National Patient Survey, which I think will be more informative. That was done in January and February. Whilst the numbers are small per practice, nevertheless, it's a helpful benchmark, and that will provide us with patients' perspectives about the quality of care that they're receiving. I think that will be useful to compare it with the dip that we saw in the results from last year, and then we'll be able to compare with the future. I think the thing that we don't measure, but which maybe we ought to and would be more helpful, is around our workforce recruitment and retention. Because I think that is a good benchmark in terms of, are we maximising our recruitment around the primary care network staff? Are we improving the number of or increasing the number of GPs, practice nurses and others within our workforce? Because I think that's one of the real challenges that we have. And I think if we as a system can be monitoring that and ensuring that we're doing all that we can to increase those numbers where practical, I think that's the thing that will help patient access and the quality of care as much as anything.
Great, that's really helpful. And we're missing our non-exec director, Becky Mulby, here today, so I know she'd concur with what you're saying as well about the quality of the data, that we need to understand the quality of care. James?
Actually, I just wanted to come back to Rob and the diagnostics. I suppose in terms of, he talked about the cancer and the work there, I suppose I just wanted to highlight to the board in terms of the faster diagnosis, which we're achieving there. We've put in kind of the target lung health checks, and that is direct. And I suppose coming back to our mission as in terms of as a board, in terms of the reducing inequalities, that's directed at some of our kind of poorest areas there, and we're seeing greater uptake there and there. So I suppose it's another success story that I think it's important that we're aware. It also kind of in terms of diagnostics is demonstrating in terms of our need to also direct it to those populations we need to there, and it's having success, and it's kind of looking to spread that out as well.
Thank you very much. We've got some colleagues who want to make comments. Rachel, Karen, and then Laura, and then we need to move on to the next item. Rachel.
Thank you, Chair. It was just to follow on about the long-term conditions, and I suppose I'm quite curious to know how that links with the launch of the major conditions strategy, because it seems to me that we're going to be moving into a position where we put a clear approach to tackling those programmes, and obviously the risk of having no funding at the moment is that you end up disestablishing something that's actually starting to make a difference, because we all know these things don't take 5 minutes to happen, does it? It takes a long time, and what we don't want, I suppose, is something that kind of says what we know is the things that are going to make the difference, but in a slightly different way, that it feels like we're having to recreate the infrastructure to support it. So it just seems slightly at odds with that. So I wonder whether it's worth, as a board, as trying to get a straight edge on what that strategy will say. I've seen some initial things, but as a board, I think it's critical for us to not lose impetus on those areas that we're just going to have to revamp again. So I just thought I'd draw attention to that, although I'm sure colleagues are all aware.
I think if we're on Teams, you'd be getting a Teams round of applause at that point. So, James, do you want to just come back?
No, I completely agree, and some of that was my discussion I had. It was kind of, we're talking prevention, and yet we're seeing this, and I think it really is. I think you're right, Rachel. We need to make sure that we're not kind of reducing things that suddenly in a year's time that we're having to kind of reinstate again there. And we have. I think it's important that we are linked in with that work in terms of the work that's coming. I do know that there have been some conversations about that we're involved in, but yeah, absolutely support that.
So let's not lose that thread, and you're helping us to have foresight as a board, which is really, really welcome. Thank you. Karen, and then Laura wants to come back on Jane's comment from earlier. So, Karen.
Thank you, and I suppose you'd expect me to say this, but there are no measures in here about how we're supporting people where they live through things like community services and the outcomes for people. So in the collaborative, we're working really hard to work out what we're going to measure to prove that we're adding value, and there's a bit of, Rob always says, you do what you measure. Or you measure what you do, whichever way around it is. So we need to get that right, and we need to work on that together in the collaborative, but we're missing a huge sector here and a vast swathe of activity that's just not in here at all.
Thank you. And I know you're going to bring those suggestions not only to the Task and Finish group, but also in your, God, we're building up your report, aren't we, for July? Great. Ian, do you want to respond?
Yeah, I mean, it's availability of metrics. If you're developing metrics as part of the collaborative and they're there, then we'd be delighted to use them.
Great. And I know people across different sectors were keen on that. Okay. Laura, we want to go back to Jane's comment on risk.
Yeah, I was just reflecting, and I think, having said I didn't want everyone to talk about process, I'm going to talk about process, but I think I'm really conscious that at the moment we've chosen an approach in terms of scoring risk where we do a current and a target. So the current is the mitigated risk score, so it's taking into account all of the mitigations, which I think is really interesting in the context of actually we've got some very high risks, and they are supposed to be reflecting mitigated risks. There is there are alternative approaches, so it isn't unusual, for example, to do 3 risk scores. So you might choose to have an initial risk score, your mitigate risk score, and then your target score. And I wonder whether the audit committee might want to have a bit of a think about that. And then that led me on to thinking around the target score and us making sure that we're linking that back to our risk appetite. So what is our tolerance for some of these risks? I think some of the target scores are very ambitious. I'm not convinced we would ever get to that. And actually it might not reflect the discussions we've had around, there are times where we want to be bold around things, open to level of risk, and I think that's a question we should be asking ourselves as we move through the risk cycles.
Okay. Thank you very much. And then linking with what Rob was talking about, inviting in programme boards and other colleagues as well as we look at those themes. So Jane, I think you asked a question and you've gone away with an action. Do you want to respond on that?
Well, I think we should start that, to be honest. Let's not wait for an audit committee discussion, because I think we need to be able to see, and it will test that sort of current scoring if you put in what the initial is, because you've got to get somewhere it suggests that actually everything we're doing is making no difference, because some of them are the higher end anyway. So I do think that will help tease out to make sure we've got a appropriate and balanced scoring that will then focus in the right areas.
That's great. Thank you. And understanding what's in our control and out of our control, but that we can try and influence. Did you want to come back, Rob?
Yeah, just to land something for the next meeting, I guess. So we've got a load of data here which is published and out of date, isn't it, compared to what we know around the table. So Mel's just given us an update on the good performance in Mid-Yorkshire on A&E, for example. And because it's about last year, it doesn't reflect our plans for this year, which we just signed off. So what we must do next time, and what's in the plan, is we've got to sign off our balanced scorecard in terms of the targets, the trajectories, and the progress against our plan. And I think that will make this conversation infinitely easier, because we should be able to draw a line between, the decisions that are being taken, the risks that we're carrying, and the impact on performance and the trajectories. So that's why the task and finish groups meeting, that's what we need to do next time. And in that, I think we'll have some of the things we've said are a priority for us, like dentistry, going to the major conditions. We know physical health checks for people with a mental illness, for example, there's some really great work going on in West Yorkshire. The Oliver McGowan training and progress against that, for example. So let's make sure that we recognise that that's happening next time, and that will help this conversation. I think I'd also want us to make sure that the good performance on EIP, early intervention in psychosis, the generally good performance on IAPT across the place isn't just brushed over as if it's straightforward or easy, because it isn't, and it's good to see that in the report as well.
Thank you. I'm going to move us now on to the next item, but also a reflection that we'll need more time when we talk next time about those documents and reports together. Okay, thank you for that discussion. That was really, really productive and helpful. We're going to move on to item 10 now on emergency preparedness, resilience and response. I never get this right. Anthony, please, EPRR.
EPRR, well done. Chair, but emergency preparedness, resilience and response, you were spot on.
Thank you.
First time. So this is just, I think, a brief update to the board following the report we brought in November, following the first annual self-assessment against the NHS core standards for EPRR. And the board asked for a progress report at the year end following that report. So that's what we have today. So there will be a formal reassessment in the autumn. So what we've done is just, if you like, made our own informal assessment of where we've moved since November on these standards. So we were at the position in November where we were saying we were partially compliant overall against the standards, and that reflected a score, if you like, of 36 of the 47 applicable standards being fully compliant. And that's now moved to a position where we think we'd be compliant in 41 of the 47. So that's moving from 77 to 87% proportion fully compliant. The paper includes details of the 6 standards where we still need to make further progress to achieve full compliance and sets out the work we're doing over the coming months to do that. So we expect to be in a position when we do the next formal assessment of being in a fully compliant position, and that will be reflected in the annual EPRR report, which comes back to the board in the meantime. So the paper's just to respond to that action from November. Happy to take any questions on how we're doing.
Thank you very much, Anthony. Does anyone have any questions at all? Majid?
Just a comment, lots of progress, good movement into the right direction and stuff. It's just a business continuity one, where it's made the sort of least progress and stuff, but you've got actions outlined below. So I'll be saying if we put those actions in place, then we'll be on full compliance with business continuity.
That's right. I think I agree, Majid. That's the area where we've had the most to do amongst the different domains of these standards. The situation is we're in quite a good position in that the ICB as a single organisation has inherited good business continuity plans in each of the 5 places. What we are working on is bringing those together into a single overarching policy for the new ICB and putting in place some of the underpinning detail that will support that going forward, and that's reflected in those points I've made in the paper. But you're absolutely right. That's the area of most focus as we build on the work that we've done so far.
Okay, thank you. Any other comments or questions? No. I had a query on the training. So last time you reported to us in November last year, you talked about training. You were going to do tests and exercises. I know we had a real event as well that was testing our policies. I just wonder if there was any learning or reflections from you or James in going through this together through training or live events.
Yeah, good point, Chair. We've actually had, as you say, a number of exercises, both within within West Yorkshire as a system, but also participated in wider regional and national tabletop exercises. In fact, there was a major national communications exercise just a few weeks ago called Exercise Major Oak that actually involved ministers and senior national officials, and that was testing a loss of communications infrastructure nationally. So we're participating fully in those pieces of work, and the West Yorkshire Resilience Forum, which is the multi-agency group that we work with, is very much part of how we're dealing with those training and exercising requirements. So yes, we are looking for the learning from them. We've also, as you say, had real incidents, including a bomb incident at St James's Hospital, which was reported in the media some weeks ago. So there are debriefs going on, again, on a multi-agency basis to make sure that we're all reflecting on how well we responded to that as a real incident, but also the exercises we've talked about, what we can learn from them. So it's very much an ongoing feature of the improvement work that we're doing.
Great. That's really helpful. Thank you. It's about being a learning organisation and learning system. And I know at our last meeting, one of your colleagues brought along learning from winter pressures, which I know both of you reflected was really helpful for Easter and bank holiday periods. It's just each time hearing about a point of learning for us and how we embed that. Okay, thank you. Fatima.
Just a reflection, Anthony, on some of the conversations that I've had with the team about maybe factoring in additional things beyond the bank holiday. So Eid, for example, I understand caused a few issues unexpectedly. And I just wondered whether when we're thinking about EPPR that we may need to think broader than what the usual suspects might be, and it might be worth having a chat about what that might look like.
Yep, very happy to do that. That'd be really helpful. Thanks, Fatima.
So we'll hear from you again in future, and going back to Majid's point, it's good to see progress, and then we'll hear more about that soon. Okay. We now move on to our AAA reports from all our Integrated Care Board committees. You'll see there that we've got the place reports as well as the Integrated Board committees of Audit, Finance, Quality. The aim by putting the reports at this point in the agenda is that we should have covered a number of items through our reporting and our risk and our performance reporting and discussions. But I really welcome inviting anyone who wants to share any progress or changes in their reporting, anything they'd like to escalate or note. But we'll take all the reports as read. But Jane, before we finish up, just to hear about the Audit Committee and the annual report would be really welcome. So AC, is this Finance, Performance and Investment Committee? Yes. Or a question?
Well, observation, yes. So I think firstly, from looking at those reports, it's great to see some consistency evolving, because specifically around the alert and advice around financial risk. So without attending some of the place committees that came through in each of those reports, and we highlighted that as well, so that's great. There is a bit of, I guess, variance in terms of what's an alert and an advice, so that's a procedural thing, but I think it will evolve over time. However, I was looking at, for example, the Quality Committee report, and there are a couple of observations there around Leeds and Bradford that were alerted, which doesn't reflect in the Leeds Place Committee or Bradford Place Committee. So it's just sort of a matter of looking at how do we close that gap, because it feels like, at least, is it the place doesn't see that as an important enough issue? So just trying to understand how do we close that gap.
I don't know, Laura, do you want to just reflect on the governance process on the reporting there?
Yeah, I can do. I mean, I can't talk on those specific instances. I do wonder if some of it is recognising the difference in dates. Those that are close to the place committees might be able to comment, but you're over 6 weeks between some of the place committees happening and, say, the quality and finance. It's just because of our cycle of meetings and fitting in. So it may be that it doesn't always directly correlate because we're in a slightly different cycle. But those that are close to those place committees will be able to comment on those particular points.
Okay. And also that a ICB committee like the Quality may have picked a certain area, service as a deep dive. Perhaps that needs to be more explicit in that as well. Okay. Majid.
Just responding to EC's point about that, I mean, it also depends what we're expecting from places, because places may have alerted the Quality Committee and think, well, do we need to alert, keep alerting? You know what I mean? So it's just, tying that sort of loose end, or that how many times do you want us to alert and where?
Yeah, exactly. So we need to be maybe just a bit more explicit. Those representing places, is there anything you want to update us on? I know, Carol.
It's just a really quick apology. On the Kirklees report, I think it's page 236, you'll notice that the first sentence in the advice section is incomplete. That's entirely my fault because I didn't go back and fill it in. But the people story last time focused on sort of urgent care responses in community. It was a positive story that we received last time. So yeah, don't know why I didn't complete that one before I submitted it. Oh, sorry.
If you would liaise with Laura, and then we'll make sure that the full version of that is out in the public domain, out on our website as well. Nancy.
Yeah, just to pick up on that specific issue around the quality report and not reflecting in the AAA report at Bradford. The AAA report's generated primarily through the board meeting and the partnership board meeting. You're absolutely right, Kathy. That was an issue around the timing arrangements for that. So I think it is worth doing a bit of a read across to see where the flows are there, because I think it's, it is a valid point. And there's just one amendment on the Bradford, well, it's not an amendment, but one update on the Bradford one. In terms of our strategy, we had 4 things we called enablers, things like digital IT. We've added research to that because it felt that that was going to be really important. So when you see more of our onion rings or pieces of pie or whatever it is you choose to call them, you'll start seeing research in there, that's why.
Thank you very much. And a reflection that you've made, AC, is you can see all places are reporting on 2023-2024 financial planning and the impact of that. And you can also see in different ways how places are engaging with local people. So I know out in Bradford District and Craven, Elaine, your place committee chair has been out on the streets with people, which is great, out in the marketplaces. And there's a report back on GP services and a wish for them to improve, which cross-references well with Health Watch's reporting. But then, as Carol's just shared in Kirklees, you've had a patient story. So it's different ways. You're all listening to local people, but you're choosing the ways in which you want to do it, which is great. Which then goes back to our place framework that we put together over 18 months ago about how places want to listen to local people. Are there any other comments on the AAA reports at all? No? Okay. Jane, do you want to come in?
Well, I think you asked me to say something about the year-end reporting, so I will. So we covered it in the alert section of the Audit Committee's AAA report on page 242. It's kind of period of heavy duty lifting for audit committee over the next few weeks, but also we're keen to ensure that the board has opportunity to review particularly the narrative and the front end of the annual report and accounts, but conscious it will be a tight turnaround time. So I would just ask that colleagues keep an eye out for an email that I'm sure Laura will send out. I'm sure it's our first as an ICB in terms of the annual report and accounts, and I'm sure people will want to reflect on sort of tone and content, etc. So, and also thank you. We have also put in an additional board meeting as well as additional audit committee meetings during this period, I'm afraid, just so that we can meet the reporting deadlines, which are tight, but encourage people to have a look when it comes into your inboxes. Thank you.
Great, Jane. That's exactly what I hoped you would say. And just a note for your diary, you should see that you've got the 27th of June in your diary for an additional board meeting via Teams to look at that. Thank you, Jane. That's really helpful. Okay, and the other thing I wanted to note is that I know during the last 6 weeks or so, our ACB committees have both met in the public domain as well as in private to test out different formats. I know that was a feedback from colleagues through development sessions over a number of months about having the opportunity to do both, and we're going to be looking later at the Constitution about how that might go going forward. But I know that those meetings in private have helped you talk about more sensitive information, issues such as serious incident or financial situation, particularly information that is not yet in the public domain. But we continue to commit to sharing the details of those discussions through minutes and this AAA reporting as well for openness and transparency. Okay. All right, we're going to move on now to our joint forward plan. Ian, item 12. Would you just give us some background to this, because this complements our strategy, but is something that we are required to submit to NHS England?
Yes, thanks, Kathy. So, as you've said, the purpose of this item is to share an initial working draft of our joint forward plan. The words "working" and "draft" are important in there. This is a work in progress, and we're sharing it early for your engagement and comment. This is a 15-minute slot, I think, Kathy. So, really keen and happy to take comments outside of this meeting as well. And I'd encourage you to share with your networks, particularly John with the Health Watch networks. I think that'd be really helpful. So as you've said, the Joint Forward Plan is a new requirement of ICBs, which was introduced as part of the Health and Social Care Act, and it's designed to be the delivery plan that delivers the NHS components of the Integrated Care Strategy, which, as you know, we signed off in March through our partnership board. The approach that we've taken to develop it is very similar to the strategy development. We've worked really closely and iteratively with places, provided collaborative sectors to develop something and build something that is owned across places and sectors and reflected in those plans as well. And that process of iteration is still ongoing. There's conversations happening each place through each place committee around the development and finalisation of place plans. We've got a good 6 weeks from today to get this right, and like I say, it's an ongoing process. You might notice that the dental section doesn't reflect the conversation we've just had, because it wouldn't, but clearly there's a little bit of work to be done there to reflect the ambitions there. 3 or 4 points just to raise, I think, in terms of where it's going next. The first one's on measurement and metrics. We want this forward plan to be more specific and tight in terms of the measurements and metrics that we're using compared to the strategy. You'll see that there's quite a lot of variation in there. Some sections are probably too metric heavy, some aren't enough, so we need to do more calibration, more working with places to pitch those right, and that's a really important part of the next step. The second point in there, we've included a few paragraphs about an improvement approach, and we're trying to use this strategy group that Rob references as a way of creating a bit of a movement behind the delivery of this plan. As part of that, we're proposing introducing quarterly improvement forums where we can bring partners together across the systems on specific issues and have a conversation that is based on peer support and critical challenge around how we're tackling issues. We started to do some of that, but we want to try and formalise that as part of our way of working in the future. The third point, and a really important point, is that the work Jonathan was doing around the financial plan, the financial position, was done in parallel with this. And we probably haven't joined those two things up as well as we'd like to. So there's a stronger story around efficiency, productivity, transformation, and how we marry this to our financial position over the next 5 years that needs to be prioritised as part of the next stage, I would say, Jonathan. And finally, we've had quite a lot of debate about how this joint forward plan should prioritise our leadership focus and our ambitions over the next 5 years versus the fact that a lot of partners want a plan that reflects the breadth of our services. If you miss something out in a joint forward plan, people think you're not bothered about it. And we've sort of debated that a few times. We had a really helpful session in February in development where we talked about some of the strategic choices we have as a board. That's influenced the dental conversation this afternoon, that influenced the operational planning process and the financial planning process that Jonathan's been through, and we reflected that in the paper, and we'll use that to influence this process as well. I guess what we're suggesting in terms of the prioritisation is that we have a joint forward plan that probably does need to cover the breadth of the services that we cover and our accountabilities, but in doing so we might draw out a number of areas in terms of increased leadership focus and increased transformational priorities rather than it being more business as usual. And what we're suggesting is we use the 6 themes from the consultation report to do that as a way of organising our sort of leadership focus, really. So that's around improving access, because we know that's really important across all services, addressing inequalities linked to the partnership board priorities around inequalities, integrating services in places and across a system, workforce and the workforce challenges that we have discussed in the context of dental, but in other topics as well, getting the basics right, which means high quality services first time, all the time, and then the sort of the funding and efficiency challenge, and as I've said, we need a really strong and clear approach on that, I think, in this plan. So that's with your support, we'll look to kind of frame the priorities around those 6 themes. In terms of the specific asks of the board this afternoon, it's comments on the document, either high-level views now or emails back. Support around that improvement approach that we've mentioned in the document, views on that approach to prioritisation and this tension between strategic priorities versus a sort of a report that reflects the breadth of our work, and recognising that the deadline for this is the end of June, so we'll be looking for a sign-off probably from Rob and Cathy at the end of June, as we did with operational planning, and bringing something back here to the July board for ratification. So I'm conscious that we've now got 5 minutes left, so apologies, Cathy, but hopefully that's helpful.
No, it's fine, and we're a little behind schedule, so I don't know if I'd really be happy to take some high-level comments, as Ian suggests, just on the sort of general context. And then I think if we can take an action from this meeting to send this document out standalone and set a deadline for board comments to come back to you, Ian, and to your colleagues. So, Fatima, your hand up.
Really great plan, Ian, to try and encompass everything that we're trying to do in West Yorkshire, which I think is incredible. I suppose just reflecting on the conversation we've just had about financial situations and priorities, I'm just wondering whether we've got the balance right between what is feasible and what isn't. So we've talked about things like personalisation and unpaid carers. My bad, because I made sure they were in there. But they're currently in the context where there isn't any resource reoccurring to support them. So we need to be mindful of that as a board. My other one is about the focus on inequality, which is absolutely right and important. But as the inclusivity champion, I would caveat that by saying that focus is really important, because we can't fix everything. So we need to be mindful of what that means in the context of this plan. But apart from that, I think it's an incredible piece of work.
Thank you. Sarah, then Julie.
Yeah, thank you. I think it's a huge ask, and I think my reflections are there's so much that's uncertain within the next 5 years. It's a question really in terms of our approach, because it's that combination of being really ambitious, because we are, in terms of the outcomes we want to achieve, but we've got to be realistic, because ambition can land as an additional demand on our staff who already feel the pressure, and that realistic around using our resources to best effect, knowing that there's not enough resources to do everything. And in particular, I'm thinking we've only got 2 years left of the long-term plan commitments for mental health, and we don't yet know what's going to come on the back of those. So it's getting this to be good enough to what it needs to do from an NHSE point of view, but flexible and adaptive enough so that we can continue to use it in a way which best enables us to deliver for the population of West Yorkshire. So I'm assuming when we're looking at things like metrics and our commitments, we will be able to adapt and flex them over time. It's not a case of we send this in on June, whatever date, and then in 2 years' time we're sorry, but kind of being our feet to the fire on delivering stuff where the whole context has changed, and then it becomes unrealistic.
Can I come back on that? Because I think you've summarised in a paragraph the challenges that we've had in this process. So the first thing is it's adaptive, and we'll need to course correct year on year, and there's a requirement, I think we'd want to do it anyway, that you refresh this plan every year. I'm not sure how prescriptive or the extent to which NHS England will oversee this plan as an entity. I think they'll be really interested in aspects of it like cancer, elective recovery, GP access, and I suspect that most of the assurance will come down those kind of mental health, come down those areas of focus rather than seeing the plan in its entirety. I think it's more important to us that we've got a plan that we think reflects who we are, what we want to achieve as a system, and then cross-checks that against the NHS England requirements.
Okay, thank you. We've got Julie, then AC, then Jane. Julie.
Yeah, I'll be brief because most what I was going to say has been covered really. Really good planning, and I think the fact we've got the VCSE running as a thread through it is brilliant. I think that strength on what will shift over that period of time, and with that investment will then follow, will be my question back, and that's where the challenge will follow, both at West Yorkshire level and at Place. And those measurables, sometimes it's really, really hard for us to deliver within the VCSE on those real hard core numbers to be able to demonstrate.
We'll go AC, Jane, and then Jonathan, and then Ian, if you want to just reflect. Thank you, Julie. AC.
Thanks, Kathy. Thanks, Ian. That's a massive piece of work. And to even put together. And just looking through and understanding how it fits with the operational plans and other sort of strategic plans that we are evolving and working in parallel. There's potential to do a lot of, there will be potential, a lot of overlap, I'm assuming, or it's trying to understand in the next iteration before it's submitted and going back to that absorption capacity in the system for that level of change based around that plan. And I've said this before as well, probably a bit of a mapping exercise would be so helpful as we do that in a sort of an abstracted form to look at some of those, because there are 5 business plans, collaborative plans that all sort of link up to that. That can be massive. So I think before taking answer, it can become an industry in itself to just sort of create those plans without having any certainty of how we'll fund or support those. So taking a pragmatic approach will be useful, but just an abstracted view would be very, very beneficial in the next meeting, perhaps.
Okay, that's really helpful. So some themes about pragmatism, being realistic, investment that we have now or investment that needs to follow, mapping exercise. And I know, Ian, you're looking at how will our programme boards, their plans, health and wellbeing board plans, our existing strategies all linked together as well, because I think that's going to be a helpful map. Again, another piece of information that helps all board members around the table as well. Okay, we're going to go Jane, Jonathan, and then we'll come back to you, Ian. Jane.
Yeah, thanks. I think I'm just sort of a bit similar to AC's comments. I think, you know, it's a great, huge, long document. It feels that there's quite a lot of overlap with kind of what we've already written in the strategy. And I guess it'd be great to, you know, this discussion about, you know, what we have prioritised and what we can do, what we can't do. I just wonder if we could, it's not easy to, certainly from a non-exec perspective, to dive in. It may be more evident to those of you in the day jobs of this to think, oh, this isn't in, etc. But it's not that easy to kind of sense that it feels like everything's in there. So somehow sort of showing us so that we're aware of what choices have been made, what priorities, what that's meant. I think that would help us kind of get a sense of, otherwise it just feels as if it's kind of everything that we want to do and maybe not as clear about where we've had to make some choices.
Great, and that complements what Sarah was saying earlier about being realistic and the pragmatism as well. Something I'm going to take chair's privilege now. One of the things I'd welcome is how we then draw that all out, because what do we have to do for 23-24 and then for 24-25, and those two sets of to-do list, as it were, and targets would be really helpful to see together. Alongside the metrics, Jane, your point about what we've already got in the strategy, so what are the metrics that sit with that? And let's make this work for us as well, as I appreciate we've got a submission to NHS England. My other point, I was looking around the room to see if Karen Coleman was here, but how do we create a version of this, final version of this document that's also accessible to the public as well? How we use infographics. Am I stealing your thunder here, Majid? Yeah. How we make something really simple and accessible, which is what we've done with our strategy as well, as this being a statutory document. Okay. Thank you. Sorry, I took chair's privilege there. Jonathan, then Majid, and then we'll come back to you, Ian.
Thank you. I mean, I think there is something about just the pragmatism and the, you know, the reality of this, but there is something also about this has been a 5-year strategy and setting out direction and ambition as well. And I think, you know, Sarah's point around long-term plan commitments only working through to March 25 is important, because that's the same time frame that we've got the financial settlement for. You know, so we don't know what the out 3 years of this 5-year plan will look like as yet. So there is something about just, you know, not promising the world, but equally setting out what would we like to do, how, you know, if we had the resources within some reasonable limits. So I think it's a real tension being able to balance the two, really, because we shouldn't stymie our ambition.
Okay, thank you, Jonathan. That's really helpful. Majid, do you want to come in? Then we'll go to Rob. Then we will come to Ian.
Just echo what colleagues have said. Very, very comprehensive document. Everything you need to know is there. Just a quick thing. Obviously, this has produced. It'd be good to have a one-pager or something about key milestones, objectives, outcomes. What does good look like? So that every now and again we can do a quick stock check with ourselves to say, right, are we going in the right direction? Is this happening, that happening? And it's also helped with the public in terms of what does all this mean to me? What can I expect? Sort of headlines for the next edition of the Daily Mail or whatever it is in 5 years' time.
Thank you very much, and I agree with you about, I'd written down objectives, aims, outputs by financial year as well. Now, it's easier said than done, Ian, but I hope there'll be something accessible for us as a board as well as for the public. Rob, do you want to come in?
I just wanted to reflect on the fact that we've been successful, I think, when we've done what's needed to run the business and the system, as well as meet the requirements of the regulator. So Ian's talked about making sure that we do the right thing and then check it against what we're asked to submit, which is the approach we try and take. In that thinking then, looking around the table, there are lots of people here, including myself, who've run foundation trusts or taken things through foundation to foundation trust status. And one of the disciplines in FT is that you have to have a long-term financial model for the next 5 years, irrespective of the uncertainties that you know that are going to come. So we should have the same here. I think to underpin this, we need a long-term financial model that says, here's what we know for the next 2 years, here's what we assume for the 3 years after that, here's our views around priorities, activity, efficiency, etc. At the moment, we all know, as I said in my introductory comments on my report, we're in a transition period, so now is the time to do it. We've gone from a load of COVID funding being in the system to that not being in the system. So we have to reset all of the finances. We know we're relying on non-recurrent efficiencies. We can't do that. We've got to right-size services and we've got to think about things differently. So I would suggest that alongside this, we need a long-term financial model, which then allows us to make clear the choices that we're making, the assumptions that we're making, and so on.
Okay. Rob, thank you for that. And we talked about this when we had our meeting last week in looking at the 23-24 financial plan as well. Colleagues around the table supportive of that, looking for the next 2 to 5 years on financial planning. Okay, thank you. That's really helpful. Ian, yeah, Jonathan. Ian, just I suppose you've got a snapshot of reflections there. We'll commit to send this document out again. Input. There are board colleagues who are not here today as well that we'd love to hear from. So, but was that helpful?
Really helpful. Yeah. I mean, just to come back on the prioritisation, deliverability, kind of absorption capacity stuff. These priorities have come from two places essentially. One is from NHS England, and two is from our own partnership. And what we know is that there's a level of churn in terms of the NHS England priorities at a time, and so planning for 5 years is quite difficult in that context, but it's the right thing to do, as we've said. We've developed that with places and with partners across the system, so that that's been sort of our test so far in terms of, is this deliverable, is this achievable? We do need to now calibrate that against the financial position that we find ourselves in, and doing that practically in the next 6 weeks is going to be difficult, but that's a task that we need to do. Absolutely clocked the need for a strategy map and a delivery map that brings coherence to the totality AC. I think that links closely to the work that Tim Riley is doing on the operating model and the role of programme boards in the future, and how we get the coherence across the whole and bring that sort of process discipline across the whole. So that's part of it. Thanks, Julie, for the comments on the VCSE. We'll continue to work with Kim and Joe around the deliverables, but it's helpful to see that we've kind of reflected it across it. Absolutely, Karen will weave a magic on this when we've got a draft that we're happy with in terms of accessible versions, videos, plan on a page, resources that we can put on our website. And it's linking back to a conversation we've had previously. I think some statement in there around conditions of deliverability for this will be important. I think the big one is, you know, on the money, and need to work really closely with Jonathan to frame that right, I think. But if you could have a look at the document when we send it out, share it, and more comments we get back, the better. We'll continue to work with Scrutiny, Health and Wellbeing Boards and other partners over the next 6 weeks as we finalise it.
Great, thank you very much. And we are gathering as a board virtually on the 27th of June to look at the annual report and accounts, as Jane outlined. So it may be a point there that you might want to reference it in that meeting, and take any final comments then by email. Okay, thank you very much to you and other colleagues who've worked on that, which is really helpful. Okay, we're now on to item 13, where we're looking at our constitution and scheme of delegation. So you've got information there, and this is one for board approval. Laura, would you just highlight what we need to look at, please?
Yeah, thank you. So our constitution and the associated scheme of reservation and delegation are kept under ongoing review, and you'll know through part of the end of year governance review process we've been looking at changes that we might need to make. And as Cathy said, we'll be looking for approval of those to support an application to NHS England for variation. So there are 4 areas of change that are proposed within the report. The first is a really straightforward administrative change that's linked to our establishment order, so that's in terms of the area covered by the ICB. I have not planned to read out the full list of 29 lower super output areas to you. If you're okay, I'll put them in the minutes. It's just a change that we've been asked to make by NHS England. We have also included the potential for inclusion of a Chief Digital Officer as an attendee at the board meetings. The third area is around, we've noted a need for additional resilience around urgent decision making. So currently it is reliant on a single individual for part of it, which is Chief Executive. So we are proposing that there are backup arrangements if an individual's not available. And then the fourth area, which is not a constitutional change, but it is linked to our scheme of reservation and delegation, is around policy delegation. So at the board development session, you asked me to look at further delegation of policies out of the board. There is a proposal set out within the paper, which is for you to delegate approval of those corporate policies which are not part of the governance handbook and don't fall within the remit of another committee to the executive management team. And alongside that, there's a proposal that we make sure that there is appropriate oversight of that, with policies shared with the audit committee prior to approval for comment. And then we would put details of all policies that have been approved in the chair's report to the board's meeting, and of course they would continue to be published on our website to make sure everyone knows what they are. I think there are 2 areas that the board might want to just reflect on. Firstly, my proposal that we exclude those policies that are part of the governance handbook. My rationale for that is that quite a lot of the arrangements that are tied to it form other parts of the scheme of reservation and delegation. So, for example, it's reserved to the board to approve arrangements for handling conflicts of interest. We can change that, but there's quite a number of associated changes. So I'd be interested in the board's views on that. And the second one is the audit committee may feel that they don't want to review all of those policies on route through. It may be that it's sensible to have a look through and see which ones the audit committee might particularly want oversight of. So I'll leave it there and see if there's any questions. Thank you.
Great, thank you. Jane, I feel like we need to come over to you first as audit chair. What are your thoughts?
I'd definitely like to look at the list and see that there's something, ones that, we may be able to, appropriately comment on, I think is fair enough, but I think there may be some on that list that are not really in our bag. So can we just have a look at it before we make a carte blanche decision, please?
Okay, thank you very much. Are there any, Jonathan?
Just building on that slightly, because if we approve this subject to Jane's qualification, I think we're setting up a principle whereby some policies will get signed off by exec directors through AMT, which isn't the case now, which I think is feels appropriate for those more operational policies. So that feels I think really sound. It's whether there's also the opportunity to look at the policies that are currently going to the Remuneration and Nominations Committee, which will include all of the HR policies, some of which will be fairly operational in nature. Whether we want to use the opportunity to have a similar sort of review to say, are there some which absolutely should go through the Remuneration Nomination Committee because it's about, you know, senior remuneration, etc., or are there some which actually are more down to exec sort of oversight and scrutiny and approval?
That seems sensible, Jane.
Yeah, I just wonder whether it would be timely following this discussion and, you know, again, a year in, just to do a mapping of, don't just assume we know what's in the governance handbook, but like map them all out, show us what is going where, and then let's just confirm or otherwise and just have a look at the entirety, because that would have picked up, I think, that point about the REMCOM kind of piece. So I think it's, then at least we know what we're working with. Thanks.
Great, thank you. So if we can do that work between now and the July board meeting?
Yes, but I'm going to need some urgent decisions on some policies that need approving before that point if we're not going to change the delegation.
Okay.
But I'm happy we can work through that as an alternative process. I can just send you around the policy register this afternoon. To be fair, it maps, they're all mapped across all of it, so we might be able to solve. It might be that we want to make the delegation decision more quickly, and then we've got a route for approval of the policies.
Okay, so we could do something by email, Jane, Jonathan, Rob? Yeah. Okay, we could do something by email as a board then and take that forward. I think Fatima wanted to come in and then AC.
Slightly different point, Chair. We started the meeting with some feedback from colleagues about the representation of people from the global majority in our decision making. I think it's really important that we acknowledge in our constitution that we've taken remedial action on that by having the Strategic Race Equality Network represented on this board, but also decision-making committees underneath that, like quality performance, etc. I did notice that there wasn't a representative on audit, and I didn't know whether that was an anomaly or whether there was some rationale behind it.
I think when we made the decision, we said it was for quality, finance, performance, investment, and transformation. There's no reason why you can't choose to put representatives onto the other two committees. That's fine.
Yeah. Okay. Thank you very much. AC.
Thanks, Kathy. I note that, of course, we agreed that we'll take out digital and people out of the FIPS committee, which we have done. However, the transformation committee in itself, there is not a terms of reference. Is that something that will...
It's on the next item.
Next item. Okay, that's fine. Sorry.
Yeah.
I just don't.
Okay. We will come to that point at a point. Okay. So we've got a little bit more work to do. We can take a board decision by email. We can ratify that back at July into the July meeting, but it means that we can keep going with this work. And just on the deputies, we note we're asking Director of Finance to deputise, and then also to note that we have two co-vice chairs as well, if I'm not around as well. So we've got deputising there as well. Okay, thank you, colleagues. So subject to those changes and that piece of work, we approve that, and we note and support that you'll submit that then to NHS England, which is good. Okay, thank you very much. AC, we now come to item 14. So these are committee terms of reference. I'm grateful to everyone working on committees at the moment for doing their reviews. I went along to observe some of the discussions that committees were having. And as I said earlier, committees were meeting both in the public domain and also in private, which was for lots of reasons, particularly having the option to meet in private to look at more sensitive issues, maybe a serious incident, as well as data that's not yet in the public domain, or talking about more sensitive financial issues before decisions were made. So we've got recommendations here to approve the amendments of committee terms of reference as well as the work plans as well. So AC, you were starting a discussion there on the Transformation Committee. Do you want to come back on that point?
Thanks, Kathy. Yes. So for some reason, I just scrolled down a bit too much. Because that's two significant fundamental part of the work that we want to focus on in terms of transformation. We realize that we don't have terms of reference for the Transformation Committee. So I think we do make a note there clearly that while we're taking that out, it's not being lost. Is that something that will get done. Yes, just thanks.
Yeah, absolutely. So the terms of reference are coming in 2 batches. So you've got 4 of the West Yorkshire committees this time, and then at the July meeting you will get the 5 place committees plus the transformation committee, which is due to meet in the next couple of weeks. So sorry, slightly longer than 2 weeks, but it will be before the July meeting. So there was absolute agreement at the Finance, Investment and Performance Committee that we should take people and digital out of it. So therefore I've gone ahead with the proposed change for the terms of reference, but that will feed into the discussion with the Transformation Committee. And we've been, I know Becky isn't here today as the chair of that committee, but there will be discussions there just as we've had at the other committee. So we won't lose sight of it. Just taking the chance to make those changes in 2 batches.
Thanks.
Okay. Any other comments on the terms of reference or the work plan for our committees? Jane?
Sorry, can we just confirm that from that, Laura, that they will be moving into the transformation board, sorry, terms of reference, or you kind of said there'll be a discussion, but I guess we would expect it to be covered by one of the board committees.
I think what we've said is that there needs to be a discussion around the most appropriate place within the formal governance structure for the people and digital agendas to come in. And absolutely expect that Transformation Committee would part of that, but there are some aspects, for example, around some of the metrics around workforce that you would still expect to see come through on the integrated performance dashboard. So what we felt was important was to work through the different aspects and map that across our governance structure. So we'll have the conversation at Transformation, and then that will come back with a further proposal around what goes into Transformation Committee and what we would map elsewhere. So absolutely committed to them being part of our governance structure, just finding the right place, and also recognising, we have a number of programme boards, and I think there's work for us to do to be more closely map those so that people understand how they're feeding into our governance structure, and that's been part of the feedback from the end of year governance review, so expect that would link into it as well.
Sorry to be pedantic, I'm not meaning to be, so when you say the governance structure, the board committee structure?
Yes, and more widely into our formal governance structure, if you like, that sets out how we make decisions.
Yeah. I guess it's just like, I would have thought our expectation would be it would sit within a board subcommittee, both of those, not that it may just drop down to exec management team or programme boards that don't kind of report in here.
It absolutely, there's no suggestion that it doesn't feed into a committee level. I think it's just around, how we, the work around the programme boards is wider than just people, and just we've talked more generally, haven't we, around how different programme boards feed into the governance structure. So yes, I would expect there to be oversight. There are lots of things that don't sit with one of our committees, but I think there was an absolute commitment that people in digital did need to, and so it's just about working that through.
It's just sort of clarifying that what Jane wants to know is the Transformation Committee is a board subcommittee.
It is a committee of the board, yeah.
Yes.
Yeah.
And
Sorry,
within that there's digital. Yeah.
Great. Kate, as Director of People, do you want to come in?
Well, thank you, but I think, Laura, you've just answered. It was a related question, because I'm sitting here thinking I'd welcome being part of that conversation about the people agenda. How much of that sits, quite rightly, in the transformation space around the wider people plan, but there is that piece about metrics and assurance, and particularly even dare I say, about the ICB workforce itself. And I'm struggling in terms of, does that sit in transformation, or does that sit still in some level of performance committee? So I think what you're saying is there will be that conversation, which is really helpful. Thank you.
Okay, so let's aim to report back on this at the July meeting. So I appreciate for you, Kate, we can ask you to come into lots of different forums and committees. There's your remit across the broad health and care workforce that links with our partnership boards and across many different sectors. There's, as you said, the ICB workforce. We also have a remuneration and nominations committee, which is mainly focused within senior leaders in this board as well. So we just need to define that, otherwise we'll have Kate everywhere and nowhere in some ways. So let's be productive. Rob?
So I do think we need to see this in the round once we've looked at it. I would say the ICB workforce, aside from the things that are reserved to the remuneration committee, should be overseen by the executive, because I think that's our job. I think the broader people, there is a debate about the broader people priorities which go beyond our ICB funding, and there's the people board, and we need to think how that fits with transformation. So there's still a bit of conversation to go on. I can see Jane's anxiety about you've decided to take something out of one of the committees without deciding where it's going.
Yeah.
I think is the nub of the matter. So I guess I'm happy to support the changes to terms of reference, but recognising that we do still have a job to do to make sure everything's covered within the governance appropriately.
Thank you, Rob. That's really helpful. Can I also just highlight, could you just talk us through, Laura, the option now for committees having private meetings? Will you just talk through what we're being asked to approve today? That'd be really helpful.
Yeah, so just to take us back slightly, so when ICBs were set up as part of the Constitution, any committees of the board that were entirely made up of board members were required, were subject to the rules around admission of press and public. That does not apply to our committees, so the Quality Committee, Finance, Investment and Performance Committee, Transformation Committee, because they're not entirely made up of board members. We did decide that we would trial during our first year opening them so that they were held in meetings held in public, so members of the public could attend if they wish to, and our papers are out on the website. So we've trialled that during this first year. We reflected at our board development session that there have been some limitations from doing that. So it has meant that it has restricted the information that can be shared, and therefore the effectiveness of those committees. And no members of the public have attended those during our first year. So there's been an impact, but actually it hasn't been something that someone's chosen to come and observe. So the proposal is that we remove the requirement for admission of press and public. As I say, it's not a requirement for those committees. But obviously it's really important to us that we continue to be open and transparent about the conversations that we're having there. And so what we would do, as we do now, is the minutes of those meetings would be reported publicly to the ICB board, and would be available on our website. And as you say, the AAA reports are the other way that we would report through. This would not impact on the place committees. It is just the West Yorkshire Assurance Committees, if you like, so the Quality, the Finance, Investment and Performance. And I'm expecting the Transformation Committee when we get to that point.
That's good. Thank you. And then I'm just talking this through, I'm thinking of a member of the public, and particularly I've had a conversation today about this, that actually with those minutes out into the public domain, members of the public could then ask questions of this board or a place committee on quality, finance, performance, and they could still have that access to that information. They can still attend the place committee meetings, and they can still attend this board meeting, and they can still ask questions of committees or those board meetings as well. Okay, thank you. That's really helpful. Colleagues, are we happy to approve those changes? For some of you that are not so interested in governance, maybe that was quite a long-winded conversation, but hopefully that's helpful. Okay, Laura, thank you to you and colleagues who've worked on this. Thanks to everyone who's taken part in surveys and discussions and reflections to make sure that our governance arrangements are right. They work for us, but they also meet the requirements of NHS England as well. Okay, so I think we have reached the end. We have. So are we taking approval of the terms of reference and approval of the work plans as a board? Thank you very much. Do we have any other business at all on the agenda today? Does anyone have anything? No. Okay, and I haven't been notified in advance of anything. Our date of our next board meeting in public is the 18th of July. That'll be taking place in Batley. And as we said, our focus on topic will be on integrated community services. Our meeting after that in the public domain will be in September, and our focus on topic for that will be on mental health services, and thanks to colleagues who are already working on those reports, which is great. So that is now the end of our May NHS West Yorkshire board meeting in public here in Halifax today. It's been a sunny day. We've been looking out the window, haven't we? Hoping that we'd be outside at some point today. Thank you, everybody, for your contributions and your preparations, and particularly colleagues deputising today for your contributions and representing your colleagues and organisations and sectors today. Very much appreciated. I think we've made progress today. We've made some good decisions. I think we've behaved in a West Yorkshire way, and particularly exercised the ways in which we want to have a bold risk appetite in some of our work together. So thank you very much. Thank you for anyone that's watched live stream or watched this on record, and thank you to members of the public that have come and observed our meeting today here in Halifax. Thank you.